could stop elimination only in one district. So, but in the last few years, we have taken several initiatives by following the process like learning from the previous campaign and then inbuilding in our existing guidelines to follow up in the coming campaign periods, and then collaboration with all our knowledge partners and bringing more transparency in the data collections and taking the real-time feedbacks and then timely response. And then during the campaign period, we review and we do take the mid-course corrections and then proper evaluations by the medical colleges and the third party also. Okay. The steps taken is mainly we developed the detailed MDA guidelines and then even the micro plan and then the reporting formats also. We have the timeline for the each activities. So we share it with the districts and at the all levels like the from the state level, district level and at the block level also the timelines are adhered. And then for each we review for the each activity also as per the timeline, and the community participation starts from the first day of the preparation. That is during the night blood survey itself we start the preparation also. The focused planning and then proper quality training and proper review. With these mechanisms, we could able to achieve much more in the MDA campaign in the state. Usually the before 22-23, the pre-MDA activities we usually prepare 1 month before, like in the issue of the guidelines and then the review of preparations, everything takes place before 1 month. But in the after 22-23, we almost take 6 months to prepare, like proper planning and the qualitative training, everything starts 6 months, so that the districts at the state level we have enough time to prepare for this activity, which is almost unique in the Odisha. Even for the next August MDA campaign, we started issuing the guidelines and even the night blood survey started. So that's how we prefer for the MDA campaign for each round and all. So the activities on the drug administration. So we just tweak the guidelines as per the state needs. So as per before guideline is one drug administrator for 250 per populations, but we changed it to the 2 DA. It's almost 1,000. It's nothing much change, but in the number of DAs has decreased. So you could able to monitor it properly, and the supervisors also OSFC it has decreased, and so that we could monitor them and we could bring more transparency among them, and their honorarium also they have some rational payment, because usually they get for 250 populations only 600 rupees around, so they could get the more remunerations. Say it brings them more interest for them to take up these activities, and lot of involvement of the volunteers also reduced, since the drug administrators are mostly related to the ASHAs and ANM. So we are managing rather than taking more volunteers in these activities. And we are having the 2 phase of trainings. Like initially when the preparatory phase, we have the first phase training. And after this household survey and the micro plan planning, we take the second phase of training we do for the DA. So we have the 2 phase of training, which is unique for the Odisha. And related to the demand generations, before 2023, we just display of the high EC materials. Only the health department has involved. And in urban and peri-urban areas, we were not getting much support. And there was not involvement of these community social mobilizers. And the fund were given mostly for the high priority villages. The IEC was focused on those hotspots and then high priority villages only. But after 22-23, we focused mostly on the interpersonal communications. Mainly, that is, as I mentioned before, during the day of the preparations, during the night blood survey, when the lab technicians, when the CHOs, when the ASHAs goes to the village for the night blood survey, what time say the interpersonal communication starts, sensitizing of the community starts. So from that we are building it, and then we engaged all the stakeholders, all the departments like education department, WCD department, Mission Shakti department. All the departments are widely participating in this exercise. And in the urban area, involvement of the Rotary is unimaginable. They helped us in all the various sectors, various activities. And we have engaged the one social mobilizers also for 2 to 3 panchayats. They have been trained properly and they are taking up the activities. And across the all village, we are sensitizing, not only focusing on the high priority, we are sensitizing all villages as per the existing fund availability. And related to the engagement of social mobilization and community participation, we engage one mobilizers for 2 to 3 panchayats, and they do the awareness activities in the colleges, schools, and then official establishments, and then village level, and then creating awareness in the among the JAS members and the MOS members. Involvement of the SHG is highly commendable, and then they involve in the community meetings also, and we do monitor their activities through the dashboard, and then the real time we do the track in which schools they are visiting, and everything we monitor on that real time basis. So per day 4 activities are mandatory and they are doing on it. Related to improve documentations and then daily reporting, before 22-23 there was not prior formal report of DAs or supervisors, it was not in place, and even the tracking of these low coverage subcenters and high refusal subcenters was not in place, and there was no proper systemic review meetings also. But after 22-23 in the village register itself, we built this daily reporting coverage reporting by the DAs. There is an online app for the supervisors reporting, and from that we could track those low performing subcenters and then high refusal subcenters, and even fortnightly review by the senior officials. Minimum 8 reviews has been are done at the state level and at the block and then district level and each level. So minimum 8 meetings, it goes exceeds also. So because of all these activities, major implication is DA requirement has gone down, but the qualitative of the DAs has improved. The supervisors also gone down, but the DAs could be able to get the rational payment, and there is a positive competitions among the districts also. Even we do the night MDA campaign also, like when the DAs going to the village, and then most of the households members may not be available because of their other activities, agriculture activities and other things. So they go in the night, and then there is a micro plan for it, and then they do the night MDA campaign also, which is unique for the Odisha. So with this trend of this MDA campaign, in 2021 the microfailure rate was 6, and it has significantly reduced. Now it is almost 0.31. So if we see the map also, like block-wise evaluations, so there is a quality of the coverage is almost sustained in all the years. It is evident from the WHO monitoring, third-party monitoring, and from the medical colleges also. So the trend of microfailure rate also, it has decreasing in trend. It's almost in 2022, most of the places were in red. In 23 and 24, it has been, we could stop elimination in most of the IUs. So what we have achieved so far, till 2019, only one district we could stop the elimination, and but now we could achieve the 9 districts, and out of 482 IUs, we could reduce to 244 IUs, and 6 districts have submitted the dossier again. So we always ensure that 100% compliance is mainly the on-spot drug consumption, not the distribution. So with this monitoring also, we have the real-time feedback monitoring with the GPS app based and all. So their geolocation tracking of monitors, it happens. Then real-time dashboard also there for them. We can analyze the performance of the monitors also. So these are the few photos of our Honorable Health Minister, sir, inaugurating the few campaigns. And then a review at our secretary level, ma'am, and then MD, and then review at the district collector, and each level there is a proper systemic reviews, as I mentioned before. So this is a few photos of the night MDA, and then refusal conversions. The medical officer, the CHOs goes in the night, they measure the weight, and then they height and weight, and then they give the tablets, and then the few photos of the CHOs convincing for those places where the refusal is happening. The cost implication, there is no much extra budget. Whatever the budget inbuilt in the NHM PIP is sufficient. It's only needed focused planning at each level, timely preparations and regular review. And so this can be applicable, is scalable also in almost all the states wherever this high burden is there. So challenges is since the elimination phase, it requires like the districts which going for the MDA campaign, and then if it is the two drugs, it is two combination drugs, it is 2 years, and three combination drugs is for 2 years, and two combination drugs for 5 years. So after that pre-task, then task. So it's the elimination phase. It's like a marathon type. It's like 8 to 11 years. We have to be dedicated. That continuous momentum has to be among the members from the state, block, and the district at each level that we have to ensure. That's the biggest challenge. And again, the number of tablets, the minimum 4 tablets we are giving, the maximum 8 tablets, it becomes the psychological barrier also in the community. So we request the ministry to change the strength of that molecules and all. And then again, as we pointed out before, the payment for this honorarium to the supervisors and the DAs might increase. They could increase. So the way forward is robust preparatory phase and use of technology wherever possible, and planning to establish this MMDP clinic at the Ayushman Mandir level, Ayushman Arogya Mandir. And then those districts which have stopped the eliminations will be going for the post-validation surveillance. So elimination cannot happen in one day, but it will happen one day. So I hope the team Health Odisha will be able to achieve most of the IUs will stop eliminations by 2025. That's what we are planning. 2025 to 2026. By 2027, we are planning to eliminate this. So thank you so much. Thank you so much.
Thank you so much, ma'am. And the last message, let's collaborate to eliminate LF from India. So with that thought, we'll move to our next presentation. We'll now hear from Chhattisgarh on innovative training approach for community health officers that focuses on enhancing the skills and capabilities of healthcare workers in this state. So let's welcome the representative with a huge round of applause.
Good morning, everyone. Respected Secretary Ma'am, respected ASMD Ma'am, respected Secretary Odisha Government, respected JS Sir, senior health officials from various states, MDs of various states, and senior health officials from across the country. I would like to present the strengthening of CHOs. It would be prudent for us to understand, Honorable Minister did also mention about the work the CHOs have been doing across the country. So in that very context, the strengthening and how we actually get work done at the grassroots level becomes more important. Uh, Capacity building of community health officers is the topic that we've chosen from Chhattisgarh. Uh, the competence, the question, the problem statement, the question, and the need for this is the competence, improving the competence of CHOs across the country, because they are the one who actually deliver the critical care and ensure the comprehensive primary health care is assured to all the citizens. Inadequate training for the CHOs is one challenge that has been identified across, and effective management of various medical conditions with ever-evolving challenges, and with the 12 extended package of services that becomes more, the utilization of their capacities becomes more crucial. This is a snapshot of what has been done. Expert consultations were widely ensured so that the curriculum and the strategy for the training is prepared. Uh, Development of training materials with the subject matter experts in consultation with the doctors and senior health experts from AIMS, Raipur. Video modules, lectures, and the training model initially prepared in Hindi, then translated to, initially prepared in English, then translated to Hindi. A cascading model in association with the AIMS. I'll certainly explain all these processes in the going forward the slides. To just give a glimpse of what has been done and what is the way forward. The flowchart actually gives a proper context. The stages and the description would be development of a standardized training module. Morning, sir. Uh, Sir, this is, as you spoke in your speech as well, sir, this is about strengthening of CHOs. and the work that is being done at the grassroots level. Uh, Developing a standardized module in consultation with the experts, various experts, with especially with respect to field experience that they have gained over a period of time, and of course with the in association with the NHRC training modules. Development of standardized lecture videos for training. This becomes more important because our whole process was more syndromic, where you learn from your experiences, learn from the grassroots uh, uh, inputs, and then convert them into guidance modules. Trainers, TOTs were conducted in association with the AIMS Raipur, where we did create a whole army of master trainers who were then adopted at the districts so that they could uh, introduce training modules at the various levels. Majorly, the master trainers were MOs and RMS. The training plan it's a blended approach which has both offline and online modes. Initially, 2-hour online classes were introduced for a period of 6 days. Once the OPDRs were complete at the PHC levels, this was mostly online, and post that, the offline mode were conducted at the district level with the gap of 6, 5, and 4 days, so that the assessment could be done. And before actually going in for the 6, 5, and 4 module, there was a pre-assessment to understand the kind of preparation or the kind of knowledge that they had before the training actually occurred. The batch comfortably had about a 30 or 35, 30 to 35 participants. Once these 654 modules were completed, additionally, high performing CHOs were sent in person to the AIMS Raipur for a 5-day training so that they could be certified and acknowledged as master trainers as well. The training evaluations, as I briefly mentioned before, it had both pre and post assessment, so understand the kind of knowledge that they have gained over the training period. The test, of course, was designed based on the MCQ format so that they could understand and express the things that have understood in a better way. Implementation, it had this actually the training module created a platform so that they could share the experiences, address the doubts and challenges while they were actually trying to understand the concepts better. This gives us a glimpse shot of the trainings that occurred, that happened in AIMS Raipur. The trainings at the district headquarters. The interventions, as I mentioned before, when you actually look at the kind of work that CHO does, these are the major, or rather the very common topics that actually come into forefront at the uh, primary level care. Fever, pneumonia, chronic pains, any sort of STIs, common skin diseases, eyes, ENT, hypertension, diabetes, with the more focus on the NCDs these days. These topics were actually included so that they could give the they could get the best of the knowledge that is possible at their level. The same was actually repeated again at the round two, where the targeted skill development was actually used. The same kind of diseases with a bit of additions, like say for example, mental illness was added at that level where a targeted skill development was done. In the round three, we had mastery and proficiency reinforcement with 2, 3 more diseases or probably topics added. Emergency management was also added at this level. And all the people, all the CHOs who actually cleared first, second, and third level were moved to the specialized training completed, which was held in AIMS Raipur, with a bit of more topics covered at their levels, so that they could also be enlisted as master trainers for the coming batches. The results and the outcome, it is there for everyone to see. The fourth column, pre-assessment, it was 22 for the first round. It increased to 31 out of 50. The 5-day training from 25 it increased to 32. For the 4th day training, it started from 30. It went on to be at 35. The AIMS Raipur training started at the base of 33 and moved on to 38. So this shows with every starting level, the base score has consistently increased over time. And the training location, this also sets a base level for us to actually plan and prepare for the refresher courses. These are the results, outcomes that we've had. There is a marked improvement in the number of OPDs, average monthly OPDs, and this gives us a snapshot of the various topics that were covered across the 3 stages. And this gives us a glimpse what actually has transpired post the training levels. The cost implication, this does not have any cost implication as such. The topic and the whole the training material have already been covered as part of the HSS NHM ka PIP, and the average allocated budget per training CHO is about 8,000. And SHRC, in consultation with the NHM and the Health Department of Chhattisgarh, has been conducting these trainings at various government venues, optimizing costs so that it can be uh, uh, propagated as a low-cost training model. Savings generated, we've started this from this financial year. Savings that were generated as part of this training modules, we have started the refresher training rounds so that the more CHOs are equipped with more kind of topics that they could deal at their own level. As an ongoing activity, this both a budget and training cycle repeats on an annual basis. These are the certificates that were given away. This was at the state level trainings, the aims, and this was at the district level once the trainings were completed. The development, these are the lessons learned and the way forward. Development of standardized training models becomes crucial and very important. Video training, especially for those who are attending online mode, if the connectivity is not better. And one-time investment, but it's scalable and offering a significant potential for wider implementation. Going forward, we have also, just one last bit to add. Going forward, especially with respect to the refresher courses, we have ensured that on the job, because a lot of people who are actually hired before the CHO's training actually started, what we have done is instead of actually putting in for the on the job training, what we have ensured is let them come for the training first, then go back to the field so that they can actually handle cases much better. Thank you so much, sir. Thank you.
Thank you so much. Well, ladies and gentlemen, from Chhattisgarh, we move to Jharkhand to its northeast, which would be presenting on strengthening of community processes through Sahiya app, a revolutionary digital tool designed to enhance the efficiency and reach of healthcare services through community health workers. Sahiya, also known as ASHA. So we'll request the representative to take this forward. Thank you so much.
Respected Honorable Union Health Minister, sir. Respected Honorable Health Minister of Odisha. Respected Honorable Member of Parliament and all the dignitaries. I thank you for giving me an opportunity to present one of the practices in Jharkhand health sector and selecting it for presentation here at the National Summit. We have, yes, in the inaugural session, we were kindly uh, requested to incorporate cutting off number of manual registers as well as portals, and also the activism at the grassroots level and the use of information technology, as well as also the use of the need for motivating our healthcare workers and through inclusion with our public representatives. So we have introduced one mobile-based as well as web-based application in Jharkhand known as the Sahiya app, and we have also a bit reform the training module and to encourage these volunteers of health department. We have also provided them some forms of incentives based upon their appraisal, and in the end we have introduced an educational entertainment cooperation with All India Radio known as the Sahiya Radio, so that not only we inform and disseminate all the health national programs to the people, but also provide a forum for the Sahiyas to share their views and experiences. So this Sahiya app is a integration of Sahiya database with spatio-temporal framework. Earlier, Sahiyas used to carry a large number of registers and make manual entries in all these registers and then travel not only in their cluster areas, not only in their village areas, but also to the block as well as the district areas to submit information and to collect and collate information. So this app is a real-time data access. It improves monitoring at state, district, block, and cluster levels. And there is a management app which enhances and consolidates all the Sahiya reporting. The earlier practice of manual reporting causes a lots of physical labor as well as the pressure to keep these records safely. In case of loss, physical loss, the sahiyas have to get it reproduced in mechanical ways as well as also to carry Xerox copies. Then, as you are aware that these are volunteers of the health sector, and to keep them their morals very high, we have to regularly engage them and also pay their incentives timely. Then there is a transition from manual to online reporting for better efficiency and accuracy. Not only their reporting is centralized and digitized, but also the claim payment is is done through this app. They undergo through these stages. They capture the claim, then the claim is approved on mobile app. Then Sathi, Sahiya Sathi, who heads a number of Sahiyas, then all these block and district level, they approve and reject the claim based upon the performance, which is also captured online. And finally, after approval from the DPC and BPMU, their payment is disbursed. It is a bilingual application. The app is available in both English and Hindi. Then it tracks newborn and migration. Some other features are delivery tracking, high risk alerts, all the works which were done by Sahiyas in their manual way, these are not digitized. You can see the training and counseling, performance and incentive management, all these are done using Sahiya app. On that side, you can see they get their login ID and password. Now they are doing it with their own mobile phones, but the state is on way to procure and provide them with the Sahiya tabs. The second aspect of this is a bit of change in the earlier training module. Earlier, a Sahiya Sathi who heads over a cluster and engages with a large number of Sahiya. Now we have come out with this practice of odd and even. One Sahiya Sathi visits a village, and the villages are numbered according to their numbers, and then the odd ones are first called, and they are given one training on one topic. Then these even one Sahiyas, they act as observer. The next day, the Sahiya Sathi will visit another village and give training on the other topic, whereas the observer will disseminate the messages and the lessons and the practices learned on the odd day. So in this way, we are able to train most of the Sahiyas in a very limited period of time. And also, it's an on-the-job training, and we are also able to prevent and save time which is there in physical training, and cover the entire gamut of 42,000 Sahiyas within 2-3 months. It is a participatory learning action program, and covering 40,000. It has helped us in reducing the cost also and saving the time also. From third-party evaluation, we have found that there are certain advantages like high community participation and demonstration of successful knowledge and transfer of knowledge. This is a component of Swasth Prahari, which was introduced in the state. It is an enhanced incentive program for the Sahiyas, and it is also the rank is being done on the 14 key indicators which the Sahiyas do, and the performance is appraised through the Sahiya app. So this also helps us in encouraging competition amongst the Sahiyas. This is the category through which we assess them. The golden Sahiyas, we have assessed around 40,000. You can see that those who score more than 90% in performing their duties, they are known as golden Sahiya, then followed by silver Sahiya, bronze Sahiya, and the Sahiyas who are not able to perform more beyond average, then they are uh, taken as a white Sahiya. So in the last 6 months ago also, we increased their incentives. The aim is to improve their motivation, attract them to perform their duties because they are at the cutting edge, they are at the grassroots, and also improve their workload balance. We also recognize them because they are volunteers, and recognition is much more important for them than any monetary incentive. So time to time, we organize all these Sahiya Sammelan at the district level also and the state level also, and also recognize their abilities. The last component of our presentation is a Sahiya radio. It is broadcasted by NHM in partnership with All India Radio. It is a 15 minutes weekly program in an entertainment education format, covers a variety of health issues and programs addressing misconceptions and providing disease-related information. Then health experts offer advice to resolve common doubts, and it is dubbed in local languages of Jharkhand like Mundari, Ho, Santhali, Nagpuri, Oraon for wider arteries. This radio is still a effective and mass means of communication in Jharkhand. And during COVID times, we were able to inform people about the need for prevention and awareness and all from time to time, all the national programs, these are broadcasted on the radio, and people also people are also participating in this program. And the sahiyas, we begin with a song of the sahiyas, and then we uh, the expert, they deliver some lectures upon them, and then the sahiyas, they also ask their questions. We also hope that we would make it more interactive by including the direct calls like we have seen in the erstwhile radio programs, where direct calls from the people all across the Jharkhand. Thank you very much. And to end, we will have 30-second radio program, if you can play.
इस कार्यक्रम के प्रायोजक राष्ट्रीय स्वास्थ्य मिशन झारखंड, स्वास्थ्य विभाग झारखंड सरकार है। राष्ट्रीय स्वास्थ्य मिशन का सहिया रेडियो कार्यक्रम सुन रहे आप सभी श्रोता भाई बहन को चंपा मुनि का जोहार।
Thank you very much.
Well, that was definitely hummable. Moving on, we'll now have Andhra Pradesh, who will be sharing their successful strategy on zero vacancy in health facilities, ensuring that all health positions are well staffed for better service delivery. We'll request the representative to take this forward.
Honorable Union Health Minister, Honorable State Health Minister, Honorable MP, respected Secretary Madam, Additional Secretary Madam, and all senior officials and colleagues, good morning all. So I'm going to talk about zero vacancy policy in Andhra Pradesh. Next. So the problem statement is that it is well known to all the people who are working in health sector that we used to have lot of vacancies wherever we go, whether it is a primary health center or sub-center or secondary health center or tertiary facilities. Wherever you go, you have huge vacancies, and because of these vacancies, the existing staff is overburdened with all the works they have to do. So that overburden definitely affects the quality of the care which we are supposed to extend, because all people of they would come in huge number to government health facilities. So the quality of care gets definitely affected because of the overburden. And in mainly the remote and rural areas or tribal areas, the service delivery will be inadequate because of the huge vacancies, always large in number in these areas. Then we used to have this problem of no promotion and lot of inquiries because of the disciplinary cases, which affects that they can't get promoted, which definitely demotivates any officer or staff working in the government system. So we have taken up this career advancement as a serious issue part of this zero vacancy policy. And we used to have notification every time whenever we go for recruitment of people required for these health facilities. But this recruitment process, it is very cumbersome. Every time you have to get the data from district, then the state level officers have to take the permission of the government. In the government system, that we need to send file to finance. Sometimes we need to take the approval of cabinet, honorable chief minister. So the entire process is cumbersome. It is a delaying one. So we have taken a lot of care in reducing this time for issuing notification and completion of the recruitment. So we have taken up interventions at various level, at institution level, at policy level, at the implementation level. So at the level of institution, first we have reorganized our health facilities in co-terminus with the population to which we are supposed to deliver better healthcare services. So we have started this rationalization with our Ayushman Arogya Mandir at the sub-center level. So we have reorganized the whole center at the sub-center level. We have created one center for every 2,500 population. Then second thing, that we have standardized the staffing pattern for all health facilities from sub-center level to the tertiary facilities. For each facility, there is a fixed staffing pattern as prescribed by IPHS. Then we have started recruiting people by issuing notification. At sub-center level, we have recruited CHOs, ANMs, and ASHAs, and these CHOs, ANMs, and ASHAs also have been equally given the burden of work, taking the population as the basic criteria. ANM has been recruited on a regular scale. Even these ANMs have been recruited for urban areas. Generally, we have ANMs only in rural areas, but the same thing has been extended to urban areas. And primary health centers also have been reorganized to match the population to which we are supposed to deliver, because you know that the PHs have to deliver in some places for 60,000 citizens, or in some places it is only 30,000, or in some places 40,000, 50,000. So there is no uniformity, there is no clear population criteria for each institution that has been standardized, and we have created one PHC for every 30,000 population to meet the criteria of IPHS. Then we found that some PHs are overburdened with a huge population. There we have bifurcated these existing PHs and created new PHs, but we have not created any additional manpower to staff these PHs. So in the process, we have created 151 new PHs in addition to the existing 1144 PHs. Then for each PHC, as I said earlier, that staffing pattern also has been standardized. So for each PHC, we fixed 14 staff definitely need to be there, and we had 2 medical officers, 3 staff nurses. Like that, we put up a proper standardized staffing pattern for each PHC, each CHC. Then even we have standardized this staffing pattern for community health centers, sub-district hospitals, district hospitals, and teaching hospitals. Then secondary and tertiary care facilities also have been reorganized on the same lines with population as a criteria. Then all these institutions have been given adequate staffing pattern as per the standardization. So in the policy level, to whatever I have explained, to implement this, we have taken a lot of policy level decisions that has been changed the existing system. The first GO has been issued in 2022. That GO was a watershed moment in our state. That GO has created a new revolution in terms of recruiting adequate human resources for all our health facilities. So that GO has given permission to all our HODs to recruit on real-time basis without going through the regular process of taking permission from the government. The one-time permission has been given. It's a blanket permission, has been given to all appointing authorities, and anytime whenever you have vacancy, immediately you go for notification and get the people recruited and get them trained and start their work. So we need not go through the regular process of taking permission every time, issuing notification every time, and we need not spend months together, years together to have adequate number of human resources required in each health facility. So apart from this, we have taken care for filling up of the vacancies whenever it is created because of the leaves, especially when you have a huge number of medical officers coming from a young generation. They used to go for maternity leave in a large scale. So those times we need to have people to fill those vacancies, for which we have created a concept of reserve doctors. So each district has been given 4 doctors to fill these vacancies, and each CHC has been given 1 reserve doctor, and whenever there is a leave, these doctors will go and do the work of those medical officers. So for that, we have recruited 289 medical officers as a reserve doctor. Then in some PHCs, because of the old system, we used to have specialists. But these specialists are not required at the level of PHCs. So immediately we have removed all those specialist posts in PHCs. They have been promoted to secondary health institutions and tertiary health institutions, and they have been completely moved. But we have created a proper mechanism that whenever we have requirement of specialists at the PHC level, they will be immediately referred to secondary health facilities or tertiary health facilities. Then we used to have different types of lab technicians at the PHC level. One person has to take care of their all types of tests, and there are certain lab technicians who have to be specially and exclusively take care of the testing of malaria or TB. But what we have done, we have trained all lab technicians for all types of tests, and we have removed this specialized testing, and we have filled up all the vacancies and all the health facilities with one lab technician, which takes care of including TB or malaria or any other type of testing. It has to be done by that concerned lab technician. Then RMNCH plus counselors. These counselors are also working at the PH level, but they are not actually recorded at the PH level because PHs are not doing many number of deliveries. So wherever their services are really required, so we have moved these RMNCH plus counselors to those health facilities where their services are really required. Then to recruit, to fill the vacancies and to recruit new people, we have created a separate state medical recruitment board on the lines of Public Service Commission. Because generally we used to go through Public Service Commission to fill the vacancies, or we need to request the concerned appointing authority to go for recruitment of new people. So for that, we have created an exclusive medical recruitment board at the in the health department itself. This medical recruitment board has been given a task of issuing notification once in a year. That 1 year notification will be valid for entire year. So whenever there is a vacancy, immediately they can take people who have been applying through this notification. Then for filling up of vacancies in tribal areas, rural areas, and remote areas, we have given extra incentives like 50% allowance honorarium is given to people working in tribal areas, and 30% allowance is given to people working in rural areas. And specialists in tribal areas, we are giving 2.5 lakh per month in tribal areas, 2 lakh per month in a rural area. But in tribal areas, we have followed reverse bidding system. Even more than 2.5 lakh, if some people are demanding more, we take a reverse bidding system. So whatever amount they quote, so we'll recruit them and we'll pay the same amount. So we have gone up to 4 lakh per month for each specialist. So by this way, we have reduced the vacancies of specialists on all these health facilities. Then we started taking or serving medical officers by giving a special reservation for PG admission. So we have given 30% 20% of admission reservation in clinical specialists and 30% of reservation in non-clinical specialists, which which gives the scope to retain your own talent within the system. Then we have taken up all disciplinary cases and conducted all these inquiries on mission mode, and we cleared all these disciplinary cases, and we started giving promotion to even people who are waiting for promotions. So these are the notification we have given at the national level through popular newspapers, and these are the photographs which shows that we have given notification and started giving appointment orders to all the people who have been selected through this process. And because of this intervention, you can see that how this vacancy has come down largely from 2021 to 24. In specialists in medical education, it has come down from 717 to 162. In secondary institutions from 1226 to 251. In PHCs, it is 0 vacancy. So we have got all 832 medical officers filled up. In staff nurses, 4,734. 100% vacancies have been filled up. Even in MLHPs and paramedics, almost 100%. We have almost 100% people recruited. And under AP Medical Recruitment Board, we have done all this maximum larger number of recruitment. That number shows that we have done this exercise through our own special board. And at present, the same figure has been given in terms of percentage. You can go through this percentage. So we have very, very less vacancy. It used to be really a watershed moment in health sector. And cost implications, in terms of cost implication, so we are filling up of the vacancies which are sanctioned by government already. So there is a sanctioned budget available, so we are not incurring any additional cost except the specialists who are recruited in tribal areas, for which we are giving certain additional honorarium that is coming to around 12 crore. Otherwise, there is no cost implication in terms of filling up of the regular vacancies. Only thing is that we need to bring changes in the policy, and we need to go for a special drive of recruiting people. So the way forward is that for scalability, so I request all the colleagues to continuously pursue with your higher political executives. So without the support of Honorable Minister, Honorable Chief Minister, Honorable Cabinet, so you cannot bring these changes at the policy level. Then when we go for such kind of a special board or mission mode recruitment drives, you need the support of political bosses. So you need to take them along, as Honorable Union Minister was mentioning in his speech, that we need to take public representatives as our messengers. So you need to, you have to tell the issue, and you have to take the guidance, and you have to implement it. And for other things, whichever I have told already, so you can follow the same, that you need to have proper assessment of the vacancies which are going to come in a year, and accordingly you need to prepare your notification and start filling the recruitment. Thank you. Thank you.
Thank you so much. Well, now we will hear from Manipur about their initiative Miron Bisingi Khudol, a gift for expectant mothers, an extension of the Pradhan Mantri Surakshit Matratva Abhiyan. This initiative aims to provide additional care and support to expectant mothers, ensuring their health and well-being. Over to you, sir.
How we go for this? Just someone, can you just respected Honorable Union Minister, Health and Family Welfare, and all the dignitaries, ladies and gentlemen. Manipur, Miron B. Singhi Kudol. Okay, this. We call it Miron B. Singhi Kudol. It is a gift. In English, it is a gift for expectant mother. It started in 2018 under the extension of PMSMA. Manipur is a hilly area, as everyone knows, is 90% is hilly terrain and 10% is valley area. What we do here is we have a limited resource, like option gynae and radiology in the hill is very few, very minimum. So we voluntarily, PMSMA, we volunteer doctors from the private setup confined to the valley area. We enroll them, and many high-risk pregnant women in far-flung rural areas remain undetected. Because of that, we started this initiative. What we do in the intervention is we enroll those volunteer doctors by identifying catchment areas of like Foxy, IMA, Rotary Club, Lion Club, and private hospital. How we motivate them is by having meetings with the Commissioner Health and Family Welfare, then with the ministers, mission directors, and maternal health division. So by enrolling them and making them enroll, By enrolling them, we recognize them in the regional, we make them attend in the regional workshop of PMSMA. Then we give them recognition and give them award. Like I placed for 9 awards for PMSMA, and by their achievements are shown in the state by through the videos and documentaries in the state program. In intervention number 1, what we do is we select the hard to reach area first. Then at least 1 month ahead, we select that and make them line list the pregnant women through mobilizing ASHAs and Anganwadi workers. And with the volunteer doctors, we choose a particular date. Even though PMSMA is held every 9 of every month, but we choose a date with the volunteer doctors by looking at their feasibilities and develop a high risk tracking format for the high risk pregnant women. After the intervention of this program, footfall increased significantly. Even significant increase of high risk pregnant detection and prompt management has been done, and we provide 100% ultrasound services also to the pregnant women. Under this, who are the stakeholders are like we enroll the and tell the local MLAs, district administrator, even they donate money, the village chiefs. Until now, we have done up to 26 health centers where we have done this program. Miron Misingi Kudol, there is a gift to the expectant mother. What are the extra activities we do under this program is provision of ultrasound services, display of nutritious food items by the social welfare department, then special special lunch for the pregnant women who comes to the camp, yoga for the pregnant women, educating pregnant women by dietitians, and awareness program. These are the few glimpses, photographs. Even sometime volunteer doctors, they come with their own vehicle and we provide them the pole. Then even to some far-flung areas, the volunteer doctors go by helicopters. Result of the intervention is we have conducted till now 26 such program conducted successfully. 2057 pregnant women reached out by the obs and gynae doctors. Out of that, we have detected 373 high risk detected, and all of them has been managed 100% due to the timely intervention. More than 1,000 ultrasound has been done in the camp, and 1057 lab tests has been done at the campsite. Counseling done for those who require services expanded. Now, after the crisis, we started from 3rd May 2023. What we have done is those relief centers where the relief, where the people are staying, we have expanded to those centers, and we have detected, we have even those volunteer doctors have seen 115 pregnant women and 55 lactating mothers to those relief camps. Outcome of the intervention is 17.5 high risk pregnant detected compared to 8.5 in normal PMSMA. 100% management of the high risk pregnant women. And what we have done after this initiative is those health facilities where the PMSMA facilities are there, we have we have increased to 132 after we started the initiative under the PMSMA from since 2018. Funding is a cost effective we don't have any extra this one allocated fund from, but all say the fund source is the district administration. They sometimes they voluntarily support the camp, local clubs, local MLAs, and even the central paramilitary forces. Sometimes for the transport, for the logistic thing, they support. And how we can scale up is to enroll more of the option gynae specialists as PMSMA volunteers. Extension of NC services in the evening clinic. We have started this another initiative under this program is by opening evening clinics in those health facilities where uh, specialists are not there. So those volunteer doctors, they go to those evening clinics and check the pregnant women. And to expand more of the non-PMSMA facilities to PMSMA facility. And we plan to expand more to those relief camps where they cannot come to the hospital because of transport, because of some monetary things, and because of all those things. We plan to extend more to the relief camps. These are even though we still have achieved so much, we still face so many challenges. Like voluntarily, the option gynae doctors from the private hospital or from the private clinics, they don't voluntarily join. And because of a hilly terrain, motorable road, even though we have planned the camp for a particular date or day, we cannot reach the area sometime because of the rainy season, because of other logistic problem. Then sometimes those doctors, because the camps are held in so remote areas that the volunteer doctors have to stay there for at least 2 nights or one night. So there is no accommodation sometimes in the far-flung areas. Thank you. Well, we have a small video clipping about 2 minutes, I think, and that is what we have done. So let us all see the.
Launched on 9th October 2018, Miron Bisingi Khudol, meaning Gift for Expectant Mothers, is a special initiative of Manipur government under the Pradhan Mantri Surakshit Matritva Abhiyan PMSMA campaign. Organized on 9th of every month or any other day, depending on availability of PMSMA volunteer doctors, the program is executed by the Maternal Health Division, State Health Society, National Health Mission Manipur, with active participation of various stakeholders, including volunteer doctors, service clubs, and community influencers. While the initiative fulfills all the objectives laid out under the PMSMA campaign, it has been specifically designed to reach the unreached and bridge the gap in accessing maternal health care services in the state. This is done by focusing on remote areas where OBG specialist and ultrasound facilities are not available and by carefully planning the event at least a month in advance. The program is conducted with active support of Social Welfare Department, and convergence activities include display and demonstration of locally available nutritious food items, yoga classes by Ayush team, and awareness program on maternal health topics like breastfeeding, high-risk pregnancy, etc. are also part of the program. During the event, registration for Pradhan Mantri Matru Vandana Yojana beneficiary is also done. So far, a total of 24 Miron Bisingi Khudol programs have been conducted, many of which were held in difficult-to-reach border areas. A total of 1,942 pregnant women received antenatal checkup from OBG specialists and 1,208 ultrasounds were conducted. A total of 360 high-risk pregnancies were detected, of which 341 have been delivered safely. Percentage of high-risk pregnancy detected is 18.53%, which is much higher than the 3.97% detection under normal PMSMA. The initiative, with its additional format of line listing of patient and caretakers, has helped in effective safe birth planning. And Miron Bisingi Khudol has become a model for better management and planning of PMSMA programs. The Union Health Ministry awarded Manipur with the first prize for rapid rollout of extended PMSMA. and encouraging acknowledgement of Mironbi Singh Khudol's contribution towards the national goal of zero preventable maternal deaths.
Thank you, everyone.
Well, no wonder they call it a gift for expectant mothers. I'd like to thank Honorable Union Minister and Honorable MP and Honorable Health Minister Odisha for their presence. So from expectant mothers, we will now move towards newborns because presenting next is Telangana on their State Center of Excellence for Newborns in the Hub and Spoke model. This initiative aims to enhance neonatal care and ensure that newborns receive the highest quality of medical attention through a well-coordinated network of healthcare facilities. Over to you, sir.
Thank you. First of all, I'd like to thank Secretary ma'am and ASMD ma'am and Joint Secretary sir and other officials here, and also Team Odisha for giving us good hospitality for running this national summit on good replicable practices and innovation in public health systems in India. So our objective is to tell about the Telangana success story in SNCU, especially special newborn care units. Yeah. So it is about a hub and spoke model, and we have set up a unit at Nilafar Hospital. It is one of the premier institute in our state, having more than 1,500 beds, especially for pediatric and maternal child health. One of the best uh, neonatal units in our state, and a lot of neonologists, both PGs and DMs and doctors also available there around the clock. So these are one of the peripheral unit. We used to get a lot of load from our peripheral units, especially from remote parts of the state, that we couldn't able to tackle the load. So we thought, why can't we use their services, especially in the other parts of the state? So major concern is about the problem statement, the low confidence levels among our peripheral unit staff and staff nurses in treating the sick bonds. One is about out of fear and lack of experience. So these really led to a lot of referrals from the peripheral units to the Hyderabad and also to the private hospitals that lead to a lot of out-of-pocket expenditure. So to avoid this one, we thought of starting a tele uh, SNC unit like video conferencing facilities among all the peripheral units with our Center of Excellence unit at Nilafar. So that we can avoid referrals and we avoid admission in private hospitals. And most important thing is the loss of valuable time, so that they themselves will take care of all arrangements in the essential peripheral units. So we started a hub and spoke model, and with specialists at hub, the Nilafar Hospital, guiding neonatal care units at the district units. The Center of Excellence at Nilafar is acting as a hub, and they try to guide and monitor the doctors and staff nurses at the district hospitals, district SNCUs, and they monitor the case by case every day, and each SNCUs at district hospitals, and they started monitoring them, and it has led to the confidence among the staff nurse and doctors at the uh, peripheral units. And also we have done the capacity building of the staff by continuous online training, and whenever there's an emergency, they'll be handheld by the staff at the central hub. The major intervention we did is the patient admission to peripheral SNCUs. So the case management has started at the SNCU level. So guidance will start from the Center of Excellence. So we have prefixed schedule for monitoring and identification of the registered cases. Not only we have trained the staff there, we started counseling the parents of newborns for neonatal care. So it also lead to the confidence among them. A senior most doctor from Hyderabad is guiding the doctors and staff nurses at SNCUs. Really boost the confidence among the parents also, and also lead to quality improvement in guidance, especially related to KMC and breastfeeding. So these are the major suggestions done by them. So most of their patients there, most of their newborns are treated, neonatals are treated by the treatment protocol given by the hub units. So this way, reduce the load at the higher referral units and also they increase the capacity at the peripheral units. So these are the intervention at the hub and spoke model. The human resource at Center of Excellence at Nilofer, we put the specialist doctor and around the clock, it's two supported by NHM and regular doctors from the Nilofer and one staff nurse also and data assistant also. And infrastructure is the crucial part here. HR is anyway available at our end, but infrastructure is about providing the video wall panel at hub and 6 individual workstation with hotlines to spokes for in and outbound calls and also the group license for the video conference platform. Same thing with the with the spokes, we provided tabs to all the SNCUs for portability and convenience because instead of providing a fixed monitor, tabs will help the staff nurse to take to the nearby to the SNCU newborn child. And also dedicate Wi-Fi connection at the SNCUs for uninterrupted video screening. This will explain you, this photo gallery will explain you clearly what are the hub and spoke model, how you started there. So what is the outcome of this one? So there's the improved efficiency in respiratory support and also increased confidence among our peripheral staff, spokes staff, so that there'll be less referrals to the higher center and also less referrals to private hospitals nearby. And neonatology started addressing the critical issues in virtual rounds. There's a time bound and fixed virtual rounds to each SNCUs from Center of Excellence. So there'll be like, they know that it will be monitored regularly by the specialist at the COE level. So it's prevented unnecessary referrals and also saving transport times. And reverse our, after once there is a serious case come to our Center of Excellence or any big hospitals, what we did is like we send reverse referrals from Center of Excellence to the peripheral units, have helped in supervision, completion of antibiotic course, and also ensuring weight gain. Because you know sometimes in essence you have to keep the baby for more than 30 days, 40 days. So we cannot keep all the, when it got stabilized, the baby got stabilized. We started sending on reverse reversal. That definitely helped us to reduce the IMR in that case. So this outcome. So total admission in 28 SNCUs before the Center of Excellence around 30,000. And after it is increased tremendously. And also referrals to the Nilofer, that is a Center of Excellence hub, it is considerably reduced from 1,732 to right now 490. So around referrals has completely come down from 5.76 to now 1.4 percentage. So it has helped us to improve the facility at the peripheral units also. What are the cost implications? So this very simple model, it can be easily scalable across the entire state. So description of the cost is around 50 lakhs for the video wall at the Center of Excellence, and annual recurring cost is around 45 lakhs. So total around 1.65 crores with the help of ECRP and NHM able to achieve this facility at both our Center of Excellence and at the spoke level. So right now the scalability is about, we have started with 18 SNCUs in 2023 and we scaled up to 28 SNCUs. And next we want to scale up to all SNCUs and NBSUs around, it comes around 84. So these are our next agenda in line. So these are the important outcome and lessons learned is most important challenge we face in the spoke is about reliable internet is a challenge, especially in remote tribal areas. So these we have to need to explore some alternate strategy for this. And significant improvement in treatment quality in all SNCUs. All SNCUs are put in use properly because they know it has been monitored continuously, regularly by someone from the Center of Excellence. And streamlining of aseptic protocols. These are also most important thing. So in entire SNCUs, I can proudly say that we have each protocol that is followed, whatever we followed in the Hyderabad, it can be followed in the remote parts of Adilabad or Badrachalam, where remote tribal habitats are there. So these are the important lessons we learned and way forward. we want to connect all the remaining peripheral SNCUs and high load NBSUs to the center of excellence. And most important challenge we want to do is about improving the antibiotic stewardship by reducing antibiotic usage. That's another important challenge. We want to do that, and reducing the, of course, hospital acquired infection rates and also IV fluid administration rate. These are the one of the important agenda we want to go forward with this one. So see, the COE is also developed as a state resource center for breastfeeding and lactation management also. Wherever we are having a lactation management unit, so we not only act as for SNCUs, it also acted as for breastfeeding and lactation management also. So thank you. Then. Thank you, Anshul.
Well, thank you. Ladies and gentlemen, now it's time to take a short lunch break. Enjoy a sumptuous lunch, but we request everyone to please come back by 2:30. For your information, for all delegates, the lunch has been arranged at second floor, and for the state officials, the lunch has been arranged at the first floor. We'd like to also let you know that we still have states of Meghalaya, Madhya Pradesh, Karnataka, Kerala, Himachal Pradesh, West Bengal, and Uttar Pradesh in the next session post lunch. So we'll request everyone to please join us back by 2:30 so that we can start the session on time. And then we also have the session on daycare cancer centers, followed by a cultural evening. So we'll request everyone to now go ahead, enjoy your lunch, and come back recharged. Thank you so much.
আসছে না ক্লোজলি নিয়ে পাখার ಐಟು ಕಡ ಫುಲ್ ಫಿಗರ್ আসলা ক্লোজ আপ নেই ওটা খাও দে বাবা ଆରେ ଆପଣ ଆସନ୍ତୁ। ହୁଁ ହୁଁ
ଦେଖାଯାଉନି
ଚଳିବ। ଚାଲ।
ସେପଟେ ସେପଟେ ଉଠାନ୍ତୁ।
हाँ, side roof, side roof. मुझसे कोयला में तो देखा हो रहा है. Oh. What did I just say? All right, ladies and gentlemen, welcome back after a sumptuous lunch. I hope you all could taste some Odia delicacies, and I hope you enjoyed it as well. Can I hear a nod? Did you try anything special from Odisha for lunch? Yes, I only hear someone from the in the first row. What about others at the back? You all have finished your lunch, I'm sure. Did you like something very specifically? It'll be nice to know that you liked our cuisine. How many of, I like that, sir. Thank you. So, I'm sure you've tasted, as I can understand, dalma, which is very, very special. And I hope you get to taste chennapoda as well in the sweet section. Did any of you check out chennapoda? If not, that is something you need to taste before you leave the state. It's something that you'll really enjoy. But of course, there are so many other delicacies that the state has to offer. So, yes, we are now, I think, recharged and ready for our next presentations. We were still left with a few states who had to give their presentation. So I'll request delegates, guests, attendees, all of those who are outside this hall, who, if you can hear my voice, which I believe is pretty loud and clear, I'll request all of you to please come inside, take your seats, and get settled. We would like to start on time because we still have quite a few states to present. We have the last session on the Daycare Cancer Center, 2 states giving the presentation then. And then, of course, after a short break, we'll also have a cultural evening, which is something that's going to leave you enchanted. We are 100% sure about it. So a lot to look forward to for the rest of the day as well. So we had ended with the presentation by Telangana on their State Center of Excellence for Newborns in the hub and spoke model. And of course, we did hear presentations from Odisha, Chhattisgarh, Andhra Pradesh, Manipur, as well as Jharkhand. We'll now have presentations from Meghalaya, Madhya Pradesh, Karnataka, Kerala, Himachal Pradesh, West Bengal, and Uttar Pradesh. So we'll have these states who would be giving their presentation. All right, we are good to go. So we'll be starting. I'll once again request, please do keep your mobile phones in silent mode before we start with the presentations. So, ladies and gentlemen, it's now time to move to Meghalaya to hear some valuable insights about the rescue mission program that aims to reduce maternal and infant mortality and which also exemplifies how targeted intervention, community participation, and strong leadership can drive significant improvement in maternal and child health outcomes. Over to you, sir. Thank you.
A very warm good afternoon to everyone, ASMD ma'am, the seniors and my colleagues. Uh, I would like to start the presentation by indicating the situation of Meghalaya where we are. Uh, the presentation today is about the rescue mission where our MMR was one of the highest in the country. When we don't calculate MMR for because we have only about 85,000 to 90,000 live births, and this is an estimation for 2020. But this was a very serious problem, particularly with this situation in mind, where we had about 7,000 villages in Meghalaya. Just to give you a context, I think a place like Manipur, which the presentation was made previously, for a similar population, they have about 3,000 plus villages. And even in other places, bigger states also, the Panchayat Raj system would be 1,500 or 2,000 odd systems to touch points for service deliveries. But for here in Meghalaya, 7,000 is a village. And we have at least 50% of the villages take more than 30 minutes to reach a primary health center, not a sub-center, but primary health center. That is the most serious challenge. And the total fertility rate in for Meghalaya also, it is almost the second highest in NFHS 5, but I think we're pretty confident it will be the topmost in NFHS 6, which is will be more than 3. So the model in which we actually wanted to go ahead with this problem is a problem-driven iterative adaptation method where we took the problem and we thought, how do we actually solve this problem in a systematic manner? Then we came up to a model through this where there are 5 important components. The citizen-state relationship, how are we actually conveying this issue or this converting this into an issue, because this was not considered as a serious issue for quite some time in Meghalaya. It was more of an accepted norm, and the local leadership at the medical officer level, the block development officer level, at the CDPO level, and we wanted to have everyone to feel that as an important issue. Number 3 was the effective use of data. We were not getting real-time information when we started with this. That time the RCH portals and etc. was in much more initial stage. We had to have our own setup portal because the language was a problem. We have 2, 3 distinct tribal languages. How do you use real-time systems to have decision-making support to see where the priorities are? 4 is addressing systemic challenges in terms of recruitment, supply corporations, other things which I'll elaborate a little later. And most important is point number 5, to build a political support. Because unless the political capital takes this as an actual issue, it will not be very good. So building that political support with our representatives, particularly the Chief Minister, was one of the most important things. And the Chief Minister took it as a mission, personal mission, to ensure that we have a much better lower maternal mortality and infant mortality, much lesser than national average. More than the indicators, it's about saving the life of every mother and child. That was the important thing. So we now Meghalaya today has the highest budget health to budget ratio. Niti Aayog recommends about 8%. We are close to 9%, and we started with 5% actually. So over the last 5 years, we've been able to touch to 8.9 to 9% because we involved the political capital and political leadership into this exercise. So what we did was, apart from the other sectoral things, few things which we understood, and there was Chief Minister Safe Motherhood Scheme, which was an add-on to JSY and JSSK, particularly to funding directly to facilities, because the local leadership are always demotivated to find out, I don't have resources and doing it things. We created transit homes. Meghalaya, as I said, has a lot of geographical issue. We have about 150 transit homes in Meghalaya. Quite a few of the officials here also visited some of them. In fact, one, I think Jay's sir last time also had inaugurated one of the transit homes quite a couple of years back, where it is run by self-help groups, so that pregnant mother from remote areas can come and stay as long, even 2 to 3 weeks. We have situation where 2 months they had to stay because their house is pretty very far, and to support that. And transport support not only for pregnant mother, their family, and even their children, particularly RBSK identified children, other people, for nutrition support also. We had given unlimited transport support. TBAs are still a major, not a major, but a 10% of the deliveries are still where with TBAs. More than 20% when we started, it has come down to less than 10% now. So we provided them to bring them to the facilities and stay with them if in case they wanted that kind of support. Because in fact, in healthcare in many countries, when we looked at Thailand and other places, they have a very integrated approach. Within the same hospital, they have other, traditional medicines and things which happen. So we wanted to create that. And the most important point here is creating the sense of trust in the system from our health workforce, that we are actually serious about solving this problem. So when we give resources and etc., it was not about going and auditing them, but it's actually holding them accountable to the outcomes. So that was the only thing. We never asked, did you pay money through a DBT and etc. No, whether the life was saved or not, that was the questions we could, and it was helpful. So you can see that this is a transit home run by a self-help group on the right side. On the left side, we also have the village health councils. We take it, Meghalaya is a 6 schedule area, completely under 6 schedule. So we do not have the panchayat rural institutions as through the normal system. There is a traditional system. Within that, we had to build this capacity. So we have about 7,000 village health councils for each of them. Without this, today morning, Honorable Minister mentioned about the Jan Bhagidari, and all of them had mentioned about it. Because in Meghalaya, during COVID, we understood, without this involvement, you cannot actually take up health. People will not own up health. So two things we had done. In fact, PM Abim subcenters, all the subcenters in Meghalaya were constructed by the village health councils. It was not through a tender and etc. It was done through the village health councils, and they have built up really well. In fact, when we had gone and asked the subcenters, each of the headmen will tell that when you ask how long these subcenters will last, without hesitation, they will say 100 years. Most of us can be challenged that any of our other works can have that kind of confidence, but they're able to do that because it's through that and well within the budget. And in fact, this is one village health council. If next time we have the team from NHM and Delhi, we can take them. Walingdo, this village does not have road. And the likelihood of it getting road is also very difficult because of the terrain. But that village has 100% institutional delivery, zero maternal death and zero infant deaths. Because of the involvement of the village health councils, how we have actually involved with them, the medical officer is there, and the medical officer takes that responsibility with the village health council, and they carry the pregnant women. In fact, 8-9 months pregnant women, they literally carry and bring them to the institutions. So it is not that the infrastructure will lead to a certain human development indicators. human development indicators with the purpose can also lead to the, in fact, now government is very seriously considering of putting a good road because that community has built up and they have delivered to their standards. Next is, of course, curative is also important because without FRUs, without very, because any pregnant woman who are normal pregnancy can go into a complication. 38 to 40% can get into a complication within the first 45 minutes of labor. It is possible. So then we need to ensure that uh, have a FRU. So we wanted to build the FRUs at the CHC level, and thanks to NHM resources and state resources, we've been able to take it and we have been able to use it. We have built up in very remote areas. We have built up FRUs at that level, at a very good level. But HR is very important for this. So when we look at this, we took the help of Tamil Nadu there, where we took very important learnings which we have had through some conferences like this. We understand and we go and we follow it up. Three things we have taken. One of them is this MOU where our medical officers go for training on anesthetic skills, ultrasound, and CMOC. And because even in Orissa, we had 2, 3 of them getting trained, but it was in a very small number. When we wanted to solve the issue with a certain timeline, we had to invest that much bulk. So we had to do that, and fourth batch of training is going on today. Since 2022, the MOU has been signed in 2022. Since early 2023, we are doing there, and you can see that the number of ultrasounds which increases. In fact, most of the pregnant women were not getting their ultrasound during their pregnancy. It was a very serious issue, and but now today you can see that 1,72,000 for April to December. It's only till December, so we have touched more than 2 lakhs plus now. Ultrasound today are available at a remote PHC in Meghalaya. It's still not ubiquitous, not everywhere, but through this partnership, we hope that we'll be able to make it everywhere. Unless we tweak our way of delivery for particular geographical places like Meghalaya or other hill states, service delivery has to be tweaked in certain way, even through like tele-ASN, CO, and etc. We need to do that, only then we'll be able to touch. So the model is like this: to strengthen the overall system to reduce this issue, so that tomorrow any other issue also we'll be able to actively reduce. And community participation, I've spoken about it. Infrastructure, we had the health system strengthening project also through the World Bank. A lot of labor rooms are constructed. All of our sub-centers are solar powered now, so they don't have the power issue. In fact, Meghalaya is probably the only place where 2/3 of sub-centers conduct deliveries on a regular basis. So most of the sub-centers are equipped with that deliveries, and with thanks to the PM Abim, we are getting another 150 sub-centers, which will be able to touch even more. And the HRH, the constitution of three things which we took from Tamil Nadu was the cooperation for this and medical recruitment board, as well as the medical supplies corporation. All the three were done. And in fact, we had one of the quickest recruitment. 50% of our medical officer vacancy was filled within one recruitment cycle. In fact, from the day of cabinet memo to the recruitment completion, it was less than 40 days. So that we will be able to do it. And data systems, I think again, we probably have the only open data portal where anybody can actually see what is the pregnancies details of each village in Meghalaya. It's open. There is no login credentials and etc. It is possible. In fact, just yesterday I got a 2 days back we got a very interesting question from MLA saying that is it true that teenage pregnancy is highest in my constituency? So that level of conversation we have been able to create with both political support and create conversation with an open data systems. And health financing is something we need to seriously work on if we have to solve systemic problems. Unless it's going to be decentralized and with autonomy, it's not going to happen. So the final thing is, you can see the results. We have been able to reduce MMR by 50%, and infant mortality also is at 24. When this year's data comes for 25, I hope 24, 25 a little later, we hope it should come less than 21, 20. And it's still considerably higher than some MMR, at least is considerably higher than national average. But from where we started 5 years back is what I wanted to stress here. And scalability, of course, this is a model which we wanted to try. It's not like a model which was ready-madely available. We had to build this model. And today we are very confident that if we use this model for other issues which are upcoming, we'll be able to have the overall bottom line of increasing the average life health span with the DALIs for the average resident in Meghalaya. The citizen-state relationship, as I mentioned again, the local leadership problem, we are using drones for diagnostics in some of the places where we could, and addressing systemic challenges. That's something very, very important. And finally, the most thing is the bringing the political support into the system. So going ahead, we actually want to uh, bring the IMR and MMR to single digits, if possible, even to nil, like that village Vallingdo, which was there in Iskasi Hills. Same model, we want to increase it for the non-communicable diseases issues and to see to that, because the adult male mortality is an alarming thing even in Meghalaya. The number of for every actually when we are looking at maternal death, when we are going through the death registers of facilities, for every mother who is dying, there are 8, 9 men dying of the same age, meaning between the age of 30 to 50. It was pretty serious, and so now we wanted to use similar model to do that. We are coming with the overall complete different decentralized finances for Meghalaya, autonomy and accountability, these two things. We're adding the third thing of competency, building competency so that they can actually address issues at their own level, competency, accountability and economy, and to have a very agile and adaptive health system. I think these is the lessons which we have learned, which we thought we'll share today, so that which can we can take forward, because most of the problems I think many of our facing have been already solved somewhere or other. This is like a forum where we can actually take learnings from one another, and we'll be happy to share what we could. I think there is a small video, maybe I'll request them to play the video.
Meghalaya faces a geographical challenge of providing healthcare services due to its difficult terrain. This difficulty in accessing healthcare services is a serious challenge.
In 2020, the state saw high maternal and infant deaths. During weekly COVID reviews, state leadership identified these deaths as symptoms of deeper gaps in the health system. In the same year, this led to the launch of the rescue mission with one core goal: saving mothers and babies. Each mother was tracked through the Mother app, ensuring timely care. Data was shared across health, social welfare, and community and rural development departments, fostering collaboration. Cross-department teams were formed at each facility, working with a shared purpose of saving lives of mothers and infants. Medical officers were empowered through the Chief Minister's Safe Motherhood Scheme (CM) SMS, giving them autonomy to use funds for life-saving interventions. Under CM SMS, transport support helped bring pregnant women to transit homes where they could stay up for 2 weeks before delivery. Communities were engaged through the village health councils, making them active participants in their own health care. To reduce delays in doctor recruitment, the Meghalaya Medical Services Recruitment Board was established. The state government also signed an MOU with Tamil Nadu government to upskill medical officers in life-saving obstetric care. Through the rescue mission, the entire health system was strengthened, leading to a significant reduction in maternal and infant deaths. The lessons from this initiative have been institutionalized into the state capability building model, a framework for solving complex challenges using existing resources more effectively. The state capability building model can be adopted to solve other complex problems and help create systems which ensure that the problem stays solved in a sustainable manner.
uh, thank you everyone. My team is also here, Dr. Neela, Dr. Valerie and SPM Nasiba. Thank you.
Thank you so much. Well, it's indeed heartening to see the commendable work done by different states in the healthcare sector, and sharing their best practices here at the summit so that we can all learn from each other. Moving on, we'll now be hearing from Madhya Pradesh about their initiative of streamlining performance-based incentive under Ayushman Bharat Ayushman Arogya Mandir to enhance healthcare delivery by motivating healthcare workers through structured incentives. Over to you, ma'am.
Respected Secretary Ma'am, ASMD Ma'am, senior officials from Health Ministry, Government of India, Secretary Ma'am, Government of Odisha, all other MDs from the states and other health officials across the country. A very warm good afternoon to all of you. Today, I, Dr. Saloni Sedana, am presenting in front of you our humble initiative of Madhya Pradesh for streamlining the incentive-based payment under Ayushman Bharat. So why there was a need to have this web portal? So this was actually the problem statement that we were facing lack of transparency in the incentive submissions and disbursement. And if there is lack of transparency in incentive disbursement, that creates a huge demoralizing effect on our health cadre, especially among the community health officers. If you are doing your work, you don't need to knock many doors to get what is due to you. At the same time, those who are not performing were not being very rigorously monitored at the state level or at the district level. So in the offline system, there was not the transparency in the disbursement, in the submission, and at the monitoring. Also, with the offline system, districts used to change their formats, they used to change their indicators at their own whims and fancies, which created a lack of standard indicators. So we needed standard indicators at the state level, weightage being given to indicator, because each and every time the same work may not be the priority. Sometimes some work becomes the priority, some other time. That does not happen very often, but it does happen. So giving weightage to them and linking the payments to them was a challenge to us. Then in the offline system, there was lack of access to reporting formats. CHO used to visit BMO office, asking for the papers, getting them photocopied. Sometimes districts used to change them. So it was a lot of lack of accessibility to formats. There was, of course, delay in the payments, delay in the submission, delay in the approval, delay in the payments. And as I said, the state could not monitor what is happening in districts. Districts could not monitor what is happening in the blocks. So this was the whole problem statement why this interventions was brought in. The objectives corresponding to the problem statement, the first objective was that we have to incentivize our health workers based on their performance, because the key objective here is that the health services to the people should be better, and that's how they should be incentivized. So we wanted to incentivize our healthcare providers based on their performance. We wanted to ensure timely payments. We wanted to reduce the grievances related to non-payment, because if a healthcare worker is running from pillar to post to get their own dues, what will be the time they will be spending in providing the healthcare services to the people? And of course, we wanted to bring the more transparency in the system. So this web portal was designed. First step was designing the indicators, and the indicators were not designed sitting in the state office. They were designed in consultation with Government of India, in consultation with the districts and the blocks. So for the performance based incentive of the individuals, 22 indicators are there, and for the team based incentives for ANM's 18 indicators and ASHA 15 indicators was designed. Then what weightage has to be given to the indicator, that was also designed. Then a web portal was developed after this extensive consultative research, onboarding all the users on this web portal, giving training to them how to submit their performance, how to evaluate the performance, and how to make the submission, make the payment. And that's how the web portal was rolled out. So this is the web portal, mparogyam.nhmmp.gov.in. It has various users, but the initiator of the portal, initiator of the payment process is the CHO. CHO, he or she does it for the individual performance-based incentive, as well as for now, they are also doing it for the team-based incentive. So ANM and ASHA are not filling up their forms. CHO is doing up for them. After they fill the achievements monthly, they upload the relevant documents also. The file then moves to BMO on the same portal. The BMO verifies whether the work they have indicated in the portal is actual work that they have done on the field. They approve it, and if they find some discrepancy, they can disapprove it also. The file immediately moves through the portal to the BAM block account manager. They verify the payment, it goes to EWIT and in the account of the CHO, ANM and ASHA, and that's how payment is released. So this is some photo gallery. This is the web page login, how they upload the documents, how they fill in their forms, how it is verified and how it is verified by BAM and how BAM releases the amount. What is the outcome of this portal? On this portal, we have 10,267 registered users. Basically, all CHOs, all BMOs, all BAMs are registered on it. All 10,267 people have been extensively trained. The outcomes are that 60% increase in the wellness session reportings has happened over the period of 1.5 years since we rolled out this portal. The 83% of the sub-health centers arms are reporting services in the expanded package, the 12 extended package services, and 72% increase in the OPD reporting at the sub-health center. And if we see the other deliverables, CHO's adaptability through using this portal has increased to the other IT initiatives also, and their adaptability to this portal and to other portals has increased from 35% to 89%. All of them are very proficient in now using this portal and other IT tools. The delay in the payment release has reduced significantly from 90 days to 16 days, and delay in the approval of the file has also reduced from 120 days to 38 days. There has been a significant grievance reduction in the state releasing regarding the payment approval, payment release, and that is well reflected. We have our own CM helpline, and I was just looking at the numbers of the grievances being raised by the CHOs. They have significantly reduced over past 1.5 years. And through this mechanism, 312 crores of payment has been made since January 2025. What is the cost implication of this portal? The portal was made in-house. We just hired a developer, that also from our own state electronic development corporation. So no private party was onboarded for this. It was prepared in-house. So we only paid the salary of that developer for 6 months till the portal was being made. The technical support was provided by a development partner and our own MPSCDC. It is being hosted on the state data center only, not on the cloud. We are not paying anything extra. So overall, all our portals, just the annual fees to our MPSCDC. And operational cost is also 1.83 lakh per annum. So I think it's a very cost effective, very economical portal. Talking about the scalability, this portal now the government of Madhya Pradesh is thinking that we'll scale it to the incentive payment to the primary health centers and to urban primary health centers as well, because right now it is only restricted to the sub health centers. Also, we want to, as mentioned in the morning, that we have too many portals in the health. We are thinking that we'll integrate the API so that if they are filling their performance on this portal, they do not need to fill it on many other portals. So it can be either this way, or if they are filling in, say, other portals, say for RCH, if they are filling in RCH Anmol, then that data is fetched from the Anmol and it is API linked to this portal. And of course, customization is possible based on the circumstances. As I told, if something becomes a priority this month, we can increase the weightage of those indicators, and that modification is also available at the state level. So what is the way forward? The first and foremost is right now it's an account based payment system and we want to move it to Aadhaar based payment system. So we will be linking it to EWIT and making it an Aadhaar based payment system. Then also we are linking to the team based incentive at the PHC and the UPHC level. As was mentioned in the Jharkhand presentation also, we are also thinking that we'll be going to rank our health officials based on their performance through this portal. And adaptability, it's an open source portal, so any other state who also wants to implement this portal can very well do so. So that is all from our side to bring in more transparency into the system and to make better health services available to the people of the state. Thank you.
Thank you so much. Well, moving on, we'll now be hearing from Karnataka on their Karnataka Brain Health Initiative, an innovative program aimed at promoting brain health and preventing neurological disorders through early intervention and awareness campaigns. So we'll request the representative to take it forward from here. Thank you. Over to you.
Thank you. Respected Union Cell Secretary Ma'am, ASMD Ma'am, Secretary Health Odisha, Secretaries and MD&HMs of different state, and Senior Health Department and Health Department officials of all the states. Today we are happy to present the best practice of Karnataka, the Karnataka Brain Health Initiative. So if we see the problem statement, 3.7 in 10, almost 37% of people suffer from one or the other kind of a neurological disorders like epilepsy, dementia, stroke, headache, and so on. So two-pronged approach is required. One is with respect to the prevention, early diagnosis, and treatment of the neurological disorders. And secondly, the promotion of the mental health. The mental wellness needs to also be promoted. So for this, an evidence-based, integrated, and sustainable model focusing on prevention and equitable care is being taken care. So these are the 5 basic pillars of KABHI. Strengthening the care pathways. So training from the ground level, strengthening the arms and CHOs and ASHAs to the level of tertiary care center so that there is a proper identification, screening, and referral mechanism established. So in this angle, we have done a massive capacity building exercises where CHOs and ASHAs have been trained. Diagnosis component pay, we have trained the doctors and nurses in the specific treatment protocols and referral pathways. All the clinical staff has been made aware of identification of such diseases and referring them to brain health clinics established in each district. And on the area of rehabilitation, especially with respect to the neuropalliative care and supportive therapies has been integrated. Targeted screening of high-risk individuals has been taken up. Wherever with the help of a checklist, we have identified such high-risk individuals and gone for a screening mechanism of identification of such people. And widespread awareness activities in both mass media as well as with respect to the interpersonal communication is taken up. Currently through WhatsApp and shortly thinking of integrating with eSanjeevani, we have taken up digital health management where teleneurology services has been provided directly from NIMANS to the level of the district hospitals. Tele-mentoring of the physiotherapists, of the psychiatrists, of the neurologists by NIMANS being done at the district hospital, and tele-rehabilitation where physiotherapists are being trained and being taught how to do the rehabilitation and physiotherapy exercises. So we have taken up integration with National Mental Health Program and NCD program, and we think of extending the same to our MNS package under the UHC and CAPHC package. This is a short video giving a snapshot of the KABHI. I request video to be played, please.
India faces a rising burden of neurological diseases like stroke, epilepsy, dementia, and headaches, which are leading causes of death and disability globally. Government of Karnataka and NIMHANS aims to address healthcare challenges such as lack of awareness, fragmented care pathways, training of doctors, the availability of drugs, and the need of multidisciplinary care. To combat these challenges, the Honorable Chief Minister of Karnataka, Shri Siddaramaya, has launched the statewide expansion of Karnataka Brain Health Initiative, a pioneering program to prevent and treat neurological diseases across the state while promoting brain health in communities.
ತಮಗೆಲ್ಲ ಗೊತ್ತಿರುವ ಹಾಗೆ ಮೆದುಳು ಮತ್ತು ನರಕ್ಕೆ ಸಂಬಂಧಪಟ್ಟಿರತಕ್ಕಂಥ ರೋಗಗಳು ಕಾಯಿಲೆಗಳು ಹೆಚ್ಚಾಗ್ತಾ ಇರ್ತಕ್ಕಂಥದ್ದು. ನಮ್ಮ ಆರೋಗ್ಯ ಇಲಾಖೆ ಹಾಗೂ ನಿಮ್ಯಾನ್ಸ್ ಅವ್ರ ಜೊತೆ ಕೈ ಜೋಡಿಸಿ ನಾವು ಇದರ ಬಗ್ಗೆ ವಿಶೇಷವಾದಂಥ ಒಂದು ಕಾರ್ಯಕ್ರಮವನ್ನು ರೂಪಿಸಿದ್ದೇವೆ. ಕಬಿ ಅಂತ ಹೆಸರನ್ನು ಇಟ್ಟಿದ್ದೇವೆ. ಕರ್ನಾಟಕ ಈ ಬ್ರೈನ್ ಹೆಲ್ತ್ ಕ್ಲಿನಿಕ್ಗಳನ್ನ ಪ್ರಾರಂಭ ಮಾಡಿರ್ತಕ್ಕಂಥದ್ದು ಬಹಳ ಸಂತೋಷದ ವಿಚಾರ. ಇಡೀ ದೇಶಕ್ಕೇನೆ ಇದು ಮಾದರಿಯಾಗಿದೆ.
The initiative involves training primary healthcare doctors to treat common neurological diseases using a standardized protocol. Coordinators from the Brain Health Initiative are facilitating communications between the PHC, Taluka, district hospitals and tertiary stroke-ready centers and NIMHANS, where advanced investigations, timely treatment and rehabilitation is provided to patients with more complex neurological diseases. A network of neurologists across the state will offer teleconsultation and telementoring services to assist patients residing in distant regions. ASHA workers and community health officers receive training to conduct screening of patients both at Ayushman Arogya Mandir and in their homes for early identification at a personal level. A crucial component will be to ensure continued and referral-based care. 32 brain health clinics have been established across all the districts of Karnataka. Brain health clinics serve as nodal centers for care and referral and ensure timely treatment for patients with neurological disorders. Each brain health clinic has a multidisciplinary care team comprising of a physician, physiotherapist, speech therapist, psychologist, nurse, and a district coordinator. Extensive brain health awareness campaigns are being carried out throughout the state to actively promote brain health within the community, educate people about prevention and early recognition of neurological disorders. A new online platform offers real-time data on neurological disorder patients, improving documentation accuracy and enabling impact assessment. The Brain Health Initiative is liaising with the existing national health programs to develop strong intersectoral coordination. The Karnataka Brain Health Initiative exemplifies an effective model of global policy adapted to local contexts and that can be implemented nationwide. Protecting brain health of people will allow them to realize their full potential over the life course and ensure well-being of society. India faced.
So coming to the outcomes component of it, this has been implemented in last 1 year. Specifically for neurological disorders, over 3 lakh people have been screened in all our brain health clinics. 48,077 specialized consultation for such patients has been made. 1,500 odd awareness activities has been done, and especially in community, nearly 2 lakh people have been engaged. 33 radio sessions have been done on awareness component, and 201 training sessions for 9,123 ground health workers has been made. So if you look into the analysis of the patients who have been identified and treated, among the common diseases which has been identified, we see that nearly 20,000 have complained about headache, while we got nearly 7,345 stroke cases identified and who have been then treated and rehabilitated, 6,000 epilepsy cases, and 7,211 other neurological cases. 27,500 odd physiotherapy care treatment was given, 45,000 nursing care, and 30,000 psychological care were given. In the digital system, we have done nearly 129 teleneurology sessions and 340 tele-mentoring sessions and 174 tele-rehabilitation sessions. So in the absence of physical presence of a specialist, these tele-systems have been largely beneficial in providing quality care at the district level. So if we come to the program financials, so annually we will be requiring, for every district unit, we will be requiring nearly around 50 lakh rupees, where the human resources is a large component which is already integrated within the state budget, and 11 lakh 43,000 is for other component like training, IEC, and so on. So the way forward for the same is that we are thankful that the Government of India has recognized this effort and has constituted a national task force on brain health, which will be proposing, which will be taking this up for expansion at the national level. WHO also has recognized this as a case study and has taken it up for the intersectoral global action plan. Now the next step forward for us is to establish stroke ready centers, so that once we have identified it, this needs to be treated at the district level. Also the awareness which needs to be increased, because if you see the numbers, we have just started the process, but to the actual level of magnitude of the prevalence of the disease burden, we have not yet reached over there. So this requires extensive awareness created, and largely what we are aiming from them is that to be integrated under these 3 programs, so that it will also become part of the national health programs and be integrated in the continuity. So thank you everyone.
Well, thank you so much. Moving on, we'll now get to a topic which is, I think, more than important for each one of us today in these challenging times. So yes, now Kerala will present the Santwanam Mental Health Project, a comprehensive mental health initiative that seeks to provide accessible and effective mental health care services to individuals across the state. So we'll request the representative to take it forward from here.
I'll request my colleague, Dr. Kiran, also to be here. Respected Secretary, Additional Secretary, Joint Secretary, and also Secretary Health Odisha, and all the other senior officers, and also my colleagues from the state, and also from NHM, and all the officers from the Ministry of Health, and also from the various states, including Orissa. Warm greeting from the state of Kerala. We will present the story, what we have been doing in mental health in two parts. I will focus on the way we think at a policy level, and my colleague will take you through regarding this one particular initiative which has been chosen for the presentation today before all of you. I will take you back to our Honorable Union Health Minister's three important points, which I have also noted. First, he said that there was a shift in the policy in 2017, and we are focusing on preventive, promotive, and comprehensive healthcare. So this is the first building block. Second, he said strengthen the grassroots, strengthen the foundation. And third point, which stuck to me, is engagement with the people's representative, Panchayati Raj system. When we will present our niche project, Sanpanam, you will realize that all these three building blocks are put in place based on which we go forward. How do we think regarding any issues in the health sector? In fact, I must say, out of my experience, in many of the health adversities we can tackle, but mental health is one of the most difficult challenges all of us face. Maybe because of two, three very common things. One, in the society, there is an enormous stigma related to mental health. Second, there is a lack of knowledge even among the educated people, including you and me. In fact, we don't know how to deal with the mental health issue if it happens in our families. So you imagine the magnitude of problem. In this background, unless and until we are having a well laid out structures and the intervention, in fact, we will not be going forward. In the, in 2015-16, when we have done this surveillance, it was a realization that at least 10.6% of adult population may suffer from one or the other mental health illnesses. And out of that, 50% suffer from the depression, and at least 1 to 2% are having a serious, psychiatrical ailments and other things. So in order to do this, what is to be done? So we take a look at what will be the magnitude of the problem, who are all the segment, and segment specific, the programs are very well tailor made. For the students, in fact, we try to find out early signs whether there are any mental health related issues. When we realize that in the maternal mortality, there is also a suicide rate, there are certain mothers who are committing suicide, that what is the cause? So we are having a very tailor-made program for that, Amma Manas. When we say that we have to take it to the primary health level, we are having our mental health program right at the primary health level. So if we take a look at all these spheres, whether we are having an intervention plan at the grassroots level, whether we are having engagement with the community at the grassroots level, whether we are leveraging our resources through Panchayati Raj. Very briefly, I will tell you one particular, I would say a success story. We are having a mental health center, 3 mental health center. And you can imagine that Honorable Supreme Court had to give instruction to all the states that you have to take care of the infrastructure and the human resource and also the service delivery in mental health center. So we have done the partnership with Banyan, which is a brilliant civil society. Many of you must have been working with them. But when we worked with them, more than 400 inmates of the mental health centers, where we were able to take them out, link them to the homes from where they belong to, or out of more than 160 those patients, they were free of any kind of a support system which were required to them in the past, and then they were managing themselves, which is one of the very brilliant outcome in last 5 years, because all these people were confined to this mental health center all throughout. So this is just one example. Now, in order to understand what our Honorable Union Minister has said, that how we can leverage at the grassroots level the strengths what throughout the country we are having, I request Kiran to take us through the Santwanam and then correlate that how we can leverage the resources what are available at our disposal to achieve the health outcomes. Over to you, Kiran.
Thank you, sir. Continuing from what Honorable ACS has said about it, we have the different interventions and programs concerning different SDG to achieve the different SDG goals, like school mental health, Amamanas maternal mental health program, Ashwasam depression management in primary care, Jeevaraksha a suicide prevention program, and mental health for all at a Grama Panchayat level called Sampurna Manasiga Arogyam, and the Sandwanam community rehabilitation program, along with what Honorable ACS had said about the Home Again program in collaboration with the Banyan. Regarding the Sandwanam rehabilitation program, it's more of a daycare center with occupational therapy being done, because rehabilitation of these patients, especially patients who are in remission on treatment but who cannot afford for themselves, who are usually facing facing a burden as a burden to the family, or express emotions from the family, rejections from the family, etc. And they are being taken in a vehicle from the adjacent Grama Panchayats to the center. The vehicle is provided by the local MLA fund, and in the center they are given occupational therapy, recreational activities, etc. I will be going through the slides for that. This definitely will help them to improve their social skills, improve the self-esteem. They are receiving some remuneration for that, and this definitely will help them in their financial independence, and definitely help them to improve the quality of their life. This was started, this is the first daycare center we have started in Mangalapuram Grama Panchayat. It was started in collaboration with the Block Panchayat, Pothangod Block Panchayat, Mangalapuram Grama Panchayat, and mental health program, state mental health program. All the technical support has been given by the state mental health program, the funding by the Grama Panchayat and by the Block Panchayats. We have a Aya and a cook as staff there, and they are given regular training by the district mental health program team for occupational therapy and other activities. The patients are taken there, brought from their homes by about 10 a.m. and then brought back to their homes by about 3:30 p.m. in the vehicle provided. The different activities being taken, mainly it is the occupational therapy there. Medicine cover making is the main activity. The medicine covers thus manufactured are brought by the adjacent PHCs and CACs. Again, the other activities including lotion and soap making, etc. The amount thus procured is given back to the patients as remuneration. The other activities include there's recreational activities, which also helps them to improve the overall atmosphere there. And the treatment compliance is ensured by the DMHP team, which visits the center once in a month along with the adjacent PHC Mangalapuram. These are the results and outcome. Social skill development, then improving the dignity to receiving a remuneration for the work they have done. Reduction for the family, that definitely improves their stress and burden, because the patients will be there during the daytime. They will be taken care of by the staff there. So definitely it will help to reduce their stress. Then and community reintegration, that is definitely helps to reduce their social isolation, improve their building relationships with other people, and helps them to participate in the society. This is the photo snaps we have taken about the activities they are doing as part of occupational therapy. Prayer, exercise, reading, newspaper reading and other book readings, medicine cover making, etc. The funds allocated is LSG funds as rupees 8 lakh per year, 3 lakh of which is for the staff working there. Another 3 lakhs is for the food supply, and 1.5 lakhs for the fuel as fuel charges. The vehicle was procured with the MLA fund from local MLA fund, and all the medicines and treatment are given by DMHP free of cost. And based on this success, we had scaled up the project to the entire state. All the 14 districts are having daycare centers now. 32 daycare centers are functioning in the state currently. And the staffs are currently in there. There will be a staff nurse and an attender there. The staff nurse are given regular training in occupational therapy. Around 550 patients are currently receiving this rehabilitation treatment across the state. The funds, other funds we are procuring for that is NMHP fund through planning and M&E head. We are receiving 6 lakhs for each daycare center in the state. The state share is rupees 10 lakhs from the state plan funds, and others are for the LSD funds. The infrastructure and space are also by the LSD funds. Again, treatment and other drugs are by the district mental health program. Definitely, the way forward, it definitely helps them to improve their self-esteem, improve their social skills, build relationships, and reduce the social isolation. And it is definitely replicable. And we are itself advocating other Grama Panchayats to start similar projects so that more and more patients can be rehabilitated in such a manner. Thank you.
Thank you. Well, now we'll hear from Himachal Pradesh on their tele-stroke project, a decentralized approach which aims to provide timely and effective stroke care through telemedicine. So, over to you, madam.
Respected Secretary Ma'am, Additional Secretary Ma'am, JS Policy, Secretary Health Orissa, MD NHM State of Orissa, secretaries from all over the country, mission directors, senior officials from Government of India, and other state officers. A very good afternoon to you all. I'm here to present the HP Telestroke project, a decentralized approach. So, the stroke epidemiology in India, one stroke happens every 20 seconds, one stroke related death every 2 minutes in the country, and the commonest cause of adult disability is stroke. So, out of the 15 lakh patients who get stroke in a year, 5 lakh recover, 5 lakh get disabled, and 5 lakh patients die. So this was an important data to get into this tele-stroke project, and the golden hour to treat these stroke patients is 1 hour. Within 1 hour, if the patient is able to reach to a treatment facility where he or she can be thrombolized, then your modified Rankin score is 0 to 1, where 0 is after 90 days when the assessment is done, the patient doesn't have any kind of symptom or disability, whereas 1 is the patient has a minimum disability, and the scale ranks from 0 to 6, where 6 is death. So within 1 hour, 60% of the patients get have a modified ranking score of 0 to 1, whereas within 3 hours it reduces to 40%, whereas the treatment window is 4.5 hours. In a state like Himachal, where we have hilly terrains and difficult roads, the ability of the patient to reach a treatment facility is crosses 4.5 hours, and they are mostly get this kind of disability after stroke. So we initiated this telestroke project in Himachal. It was initiated in 2014, and we had two hubs, that is IGMC Shimla and Tanda Medical College, which were the established medical colleges of the state, and full-fledged neurology department was functioning. And we had 17 spokes having the CT scan. As diagnosis of a stroke patient can be done only through CT scan machines, the spokes were identified which had CT scan facility, and the physicians and casualty medical officers of these 17 facilities were trained on thrombolysis and the management of stroke patients, and 108 ambulance staff was sensitized to identify a stroke patient and make them reach the nearest facility where this thrombolysis is available. And 4 neurologists were made available 24/7 in the hubs to advise the medical officers on treatment. And WhatsApp was used for transmitting the CT images, and a connector place was made available free of cost. The smartphone based app was also developed. The application was developed by NIC, and there are two features, one for doctors and the other for the patients. Doctors have access to the standardized protocols. Patient data is fed by the doctor in the app. And feature for patients and 108 ambulance is it is to identify whether the patient is having stroke. Has a feature also to send emergency SOS to the medical officers in the treatment facility. So shows nearest active spoke and also opens the GIS navigation to reach the center. And it also has IEC material in English and Hindi. So the results are here to see. 831 patients were thrombolized till date in spokes. We have data from 2019-20. Though the initiative was done in 2014, it took off very late. And 2019-20, there were 77 patients who were thrombolized at the spoke level, which has increased to 104 in 24-25. And as you see, the patients in the hubs who were thrombolized is getting lesser and lesser. And this is a thing that you can all replicate in the states. It is just that we do have neurologists in the states, and if we make them available and make a WhatsApp group, this is possible with some training to the casualty medical officers and the physicians in the treatment facility. So challenges that we face as on today also, when there is a facial paralysis or a stroke patient, they tend to reach this quacks because they feel that this can be better treated by the quacks. And doctors at spoke, still they are apprehensive about the bleeding complications. More spokes are required for better penetration, and not to miss the golden hour, that is 1 hour within the uh, occurrence of a stroke. So the way forward, we are improving our diagnostic facilities, and 17 more are getting added very soon, and comprehensive IEC strategy to increase awareness among the patient, and continuous capacity building to improve the confidence of the doctors. Thank you.
Thank you so much, ma'am. We'll now have West Bengal presenting on their integrated viral hepatitis services in correctional homes, establishing synergy. This initiative focuses on providing comprehensive hepatitis care within correctional facilities, ensuring that all individuals receive necessary treatment and support. So over to you, sir, for the presentation.
Good afternoon, senior dignitaries and officers of the Government of India as well as the State Government of Orissa. I, MD NHM, firstly thank Government of India for giving opportunity to West Bengal for presenting here at the 9th National Summit. I also take the opportunity of thanking the State Government of Orissa for offering such a warm hospitality and wonderful arrangements during our stay here. Well, the topic that I'm going to talk about is regarding the impact of synergic efforts that we could make in having a significant impact when it comes to tackling viral hepatitis in correctional homes. Now, why viral hepatitis? Now, viral hepatitis usually is a lesser spoken disease, but it is a silent killer. If we can see that the worldwide, right now, hepatitis B burden is 254 million, and out of which India contributes to 30 million. Hepatitis C, worldwide 50 million. India contributes 6 million. Now, why I say hepatitis B is a very silent killer, because it's a chronic disease. It's actually not curable. It actually involves a lifelong treatment. Its prevalence is 8 times more than HIV. Its mode of transmission is similar to HIV, which means infected needles, sexual contacts. Mortality rate of hepatitis B is equal to TB, and hepatitis B happens to be the only communicable disease which today shows a rising trend all over the world. Now, if we look within the Indian context, we see that West Bengal has a higher prevalence of hepatitis B when compared to the national average. But when compared to the national average as far as hepatitis C is concerned, West Bengal is slightly lower than the national average. So in this broad context, when we did the population profiling of hepatitis B, we saw that it is the correctional home inmates who have a higher prevalence of hepatitis B as well as hepatitis C when compared to a general population or a slum-centric population. So we realized that we need to have certain specific interventions at correctional homes so as to remedy the state of affairs. The WHO policy brief for people in prisons document also talks about this, that there is a disproportionately higher numbers of people affected by this disease in correctional homes. Now, the initial problems that we understood that we are going to face when we are dealing with correctional homes, because normally in a correctional home, the only tests that are done are HIV tests, and this table just shows that on an average last 1 year, what were the normal number of HIV tests conducted. But other than HIV, we never used to conduct any other tests other than those routine tests when someone falls ill. So we understood that the reach of health programs in correctional home was suboptimal. We understood that correctional home is a different sort of an ecosystem when we compare it with any other, because it involves jail inmates. So their movement involves security, infrastructural problems. So we had to take into consideration that. We also had to take into consideration the fact that, the staff and the officers of correctional home are not very used to the health setup. Similarly, if we want to even send mobile teams from district, that will also can only be periodic, cannot be regular. We are going to have logistic hurdles. And there is also a high turnover and transfer of under trials detainees. So to track a particular case of viral hepatitis happening in a correctional home is indeed a challenge. And if an inmate is finally released and when he goes back to the community, then also it's a problem because we are missing out on opportunities. So these are the problem statements based on which we decided to make an intervention. Now, when we talk about the intervention, we started this project on World Hepatitis Day. That was on 28 July 2021. Now, in 2021, we thought that even if we do screening of all the inmates, first as a pilot and then maybe expand it, we would still be facing 3 different scenarios. The first scenario is an ideal scenario where I take the sample and then I can measure the viral load in the correctional home itself. That is possible only if I have a TrueNat machine in the correctional home. Now in our present case, there is one correctional home where we could actually set up the TrueNat machine there. Regarding the biochemical test, it goes to a nearest lab. If the person comes out to be positive, then the patient does not have to move. The correctional home itself is made a regional referral treatment center. So that is the best and the the first scenario we are talking about, and that is my way forward when I go to the end, that we all want to finally move there. The second case is where I do not have a TrueNAT facility in my correctional home. So I'll have to map a nearby TrueNAT facility and then send the sample there. And then the regional referral treatment center may not be the correctional home itself, it may be some other center. So that would actually involve the movement of the inmate once. Again, a sort of risk and infrastructural problem. The third case was at that point of time, it is no longer valid today, because when we did not have enough of TrueNAT machines, then we had to actually send the samples, and that may be even at that point of time outside the district. So when we started off as a pilot in initially 2 correctional homes, and then now in all 60 correctional homes we are offering these services. Initially we used to draw blood from the arm, but that also has certain medical issues and also the sample thing issues. West Bengal is the first state to roll out this whole blood finger prick test for hepatitis B, as well as, actually it's missing here, is hepatitis C also. The moment we switched over to that model, and then what we did was we trained the staff of correctional home. It's not our health staff who will be present there, it's the staff of correctional home, because it's such an easy prick method that they will use to do this pricking. Now 4 central correctional homes out of these 60 have already been made as regional referral treatment center, out of which 3 of them actually already have the TrueNAT machines. So these are some of the pictures that when we started the services. Then we realized we could scale it and make it different by tagging it with telemedicine. Now West Bengal has a very strong telemedicine infrastructure backbone. We offer in any way through our telemedicine network average 75 to 80,000 new telemedicine consultations every day. So we thought we'll leverage on it, and then we started from last year February telemedicine services in correctional homes. In the last 1 year, we have given not only general 2,579 general teleconsultations, but we have now expanded to giving them specialist teleconsultation services also, which helps in follow-up of cases of viral hepatitis, because it involves gastro issues too. So what was the outcome? So the initial year when we started off, so these were the number of inmates screened at correctional homes, the number of hepatitis B and C patients found positive, linked to care, and put on treatment. Now important thing about the nature of hepatitis B is that not all patients, once tested positive, actually need immediate treatment. A treatment regime is usually made tailor-made for the patient. So some may require immediate care, and that care may require for the rest of their lives. For some people, they may not need immediate medication, but from time to time, they need to be linked with a health facility for follow-up. So this mapping and testing, this mapping of all this correctional homes was done. The greatest impact was before we started this program, the turnaround time from initial screening to beginning of treatment was almost 2 months. It was 1.5 to 2 months. Now it has reduced to less than a week, because we'll see in most cases the patient does not have to travel, even the sample doesn't have to travel in many cases, where I've converted the correctional home itself into a treatment center. Also, we linked our viral hepatitis treatment centers, which we says VPTCs, with the district health authorities, so that people who are released and go back to the community, the follow-up is done by the district health authorities. Now, some of the lessons learned is lessons with regard to synergy and convergence. First, this is an excellent example, I believe, of a convergence between the National Health Mission and the Department of Correctional Services. It wasn't easy, because people in correctional services are not used to doing this, but to train them, motivate them, and then Actually, they are doing the work of this sample collection and everything. Health only facilitates the movement and tracking. Now that is a classic example. I would also say another great lesson of synergy here was the synergy we could do with the by linking them with the telemedicine network. Third, that we are now thinking, third that we are now thinking of taking the way forward is first because of our commitment to have TB Mukt India and TB Mukt Bangla. So what we are already have roughly around 350 odd TrueNAT machines already in the state. So now we are thinking of actually utilizing the TrueNAT machines, the idle time of TrueNAT machines, by also doing the viral hepatitis screening there itself. Because it's only that the two chips are different. Viral hepatitis chip is a different chip and the TB chip is a different thing. But our next step is that so as to reduce idle time of TrueNAT machines and to ensure convergence of one program division with the other, we are going to increase the number of regional referral treatment centers from 4 to 9. 9 because all the central correctional homes now in the state in the next couple of months will be converted into regional referral treatment centers. So no need for the inmate to, or the patient to move also. Next, we have done this follow-up treatment because what happens is even if inmate has to move to a different regional referral training center, treatment center, when he comes back, the parent correctional home is now equipped. That is our objective, to make it equipped so that the follow-up treatment can be done at the correctional home itself and the inmate doesn't have to go to the treatment center again and again. We are planning to set up drug depots in the parent correctional homes itself so that the drug availability is not an issue. By the next 1 month, we are planning to roll out telemedicine in all the 60 correctional homes of West Bengal. So this is our way forward. And of course, we have the new vaccine, the vaccine of hepatitis B in place. So we are also planning for hepatitis B vaccination of those who are screened negative so that they can be protected in the near future. Thank you from our side. Thank you.
Thank you. Well, last but not the least, we'll now hear from Uttar Pradesh presenting about the behavioral training of HR project, which focuses on enhancing the skills and capabilities of human resources to improve organizational efficiency and productivity. So over to you, ma'am, for the presentation.
Good evening all. Respected Secretary Ma'am, Additional Secretary Ma'am, Joint Secretary Policy Sir, Joint Secretary RCH Ma'am, my fellow colleagues from Government of India, from different states and the host state of Orissa. Thanks for giving this opportunity, ma'am. We were not expecting we'll be presenting it, but thank you for the consideration. And though it's a very small intervention, but one of the most important intervention to bring any of our projects, programs, schemes into the reality as per the mandate of the Government of India as well as the mandate of the Health Department. So this is regarding the behavioral training and the behavioral changes to be brought up. Next slide. Next slide. First one, please. Iske baad, next. So this is regarding the behavioral training for the hospital staff. So let me tell you how we reached here. So we were sitting as a team and then we decided where do we look UP after 5 years. So we started working the workable strategies for Uttar Pradesh. So first was like saturation, because there are lots of gaps in our state, whether it is with respect to infra, drug, diagnostics or HR. So first was saturation. So we thought we'll take up on a saturation mode in the next coming 2 years. We'll saturate the state. Then second was the functionality. Whatever has been saturated, we'll go for the functionality. Third was the quality, which means the NQuas or the state, all other types of qualities. And the fourth one was saturation. So while working on all these 4 things, we found out even if we fill all these gaps, whether it is infra, HR, diagnostics, drugs, there's one thing which is left out, which is given as a feedback to us from the Mera Hospital portal of Government of India. So when we analyze this data, we have lots of data, all the states we all know, but analyzing the data, we reach to a particular, it gives lots of answers to us. So this data of Mera Hospital gave us 2-3 inputs to us, which were very important, and they played the core for any of our schemes to be successful. The data spoke like that. This initiative which started was to capture the patient feedback for the services received at the hospital. And it helps to take us to corrective actions to improve the quality of healthcare delivery and patient experience, especially the satisfaction level. So we studied the satisfaction level of the patient. If you see the slide, it's self-explanatory. Very satisfied, 36% of the patients were found, because it is a call center based message and a calling center kind of a thing. After the discharge, the patients are asked from the call center about the feedback. If they say they're satisfied, the call is stopped, and if they say it is not satisfactory, so the different questions are asked, and in those questions, they are mapped up and they are taken up into the system. So the satisfaction level, if you see, it is 36, 37, 27% of the patients are not satisfied. It means almost 1/3 of the patients are not satisfied. So then we next reach to the next level. What are the reasons of dissatisfaction? So if you see the big blue line, it is they are saying that 40% they are the staff behavior. People are not satisfied with the staff behavior. Then cleanliness 12%, cost of treatment 27%, not much, and zero based upon the quality of treatment. People didn't have a doubt about the quality of the treatment they are giving. And other reasons 26%. So the major reason for dissatisfaction was the behavior of the staff. And the surprising is the next third one. There's a cadre wise when we went into it. It was the doctor's behavior, 41%. Means we are the leaders in our facilities. 41% it was related to the doctor's behavior. Then nurses, then lab technician, other paramedicals. Pharmacists 7%, ward boys none, 0, and the other staff. So this data was from the April 23 to June 30th. We collected the data which was already existing there, and then we tried to read and try to find out a strategy for it. So we took up all district hospital facilities into it, because CSCs we have not gone into it. So next stage only we will taking up. So in district hospital, 104 district hospitals we took. Next slide, please. So out of the 104, we tried for almost all the facilities, but 87 have been mapped up, and we had got a result of 18 district hospitals only. So this data led us to think that what we have to go ahead, how we have to go ahead. So the strategic approach we had to think was, okay, first let us go through the patient journey, how the patient starts the journey with the health system. So first, if you see that patient enters into like identification critical touch points where behavior plays a pivotal role, like as soon as the patient enters into the system, at the entrance, they meet the security guard, or first any of the helpers out there, or at the receptionist. Then at the receptionist, then they go to the emergency or OPD. In emergency and OPD, then they go to the pharmacy or pathology for tests or for some radio diagnosis के लिए. And from that, they go to IPD or to the labor room or OT. And finally, either they get fully cured and they get discharged, or they are referred to the higher system, or they are sent back to the next lower system. Or if in case, despite our hard work, the patient is no more, then the family has to go to up to the mortuary level. So we have taken this mortuary because it is an emotional phase. At least when the patient is not well, so they are trying to save the patient. But once the patient knows that there is nothing left, so at least they expect that the behavior of the people surrounding the patient should be so much humanistic. At that point of time, they expect a humanistic behavior from the staff who is dealing with that previous patient who is no more. That humanistic angle is missing at many places. This is what we found out. So that's the reason we have kept that word specifically. So this is the first one. So we worked, we studied, and then we tried to find out the different reasons with lots of feedbacks, calls. We reached out. This could be the possible strategies in the future. So what strategy we could make out? One was the capacity building. Capacity building of the facility staff. From the top, from the doctor till the ward boy, Aya, home guards, and at the entrance any guard apart from the home guard which we are having. So we had gone for training of these people, and we tried to inculcate the feeling of mentorship, not only the teacher and the student relationship. We had used the word specifically as a guru shishya and accountability of these each and every leader. Then third, we used as a reward as well as recognition strategy. We work hard. Hardly anybody appreciate our hard workers. We try to find out if there is small mistake, everybody will fall on that concerned person ki aare galti kar diya, mistake you have made and this you have not delivered this much. But nobody appreciates the hard works. So we did a pilot on that. Why the behaviors had gone wrong, we tried to study. Except doctors, we recognize doctors somehow, but lower than the doctor staff, like any paramedical or even to the fourth class level, we hardly recognize anybody. So we tried, we'll take recognize and give certificates or at least appreciation on the special days, even to the lowest staff. So the names of the best performer of this month and the good employee of the month, the way you get in KFCs and McDonald's, same way we thought we'll have on the hospital facility board, the name of the best people of that particular month. So this is how we tried to chart out a strategy, and then we came up with some of the behavioral training modules, and this is one kind of a module we printed and then we used it in different trainings. So it is in Hindi, very simple, hardly 40 pages. We have tried to make it as a one pager for each and every level. So and elaborating them at the different levels. Next, please. So in this intervention, so we reached to one small note. I will say this is a cycle. You can see these were the contributors: Government of Uttar Pradesh, different directorates, NHM, KGMU, our university there, which gave psychological trainings at different levels. SIHFW is a training institute of this our place. CMSs, the leaders of the all health facilities at the district level. UPTSU, PSI, which specifically worked and UNICEF. So these four pillars we used it like adult learning training principles, because adult learning is a tough one, because it's a conditioning from the childhood. It's difficult to change a behavior of a person beyond an age. Then participatory approach, we worked on case studies, work activity based. Then the personal reflections. Many of the patients had been behaved very well. If some staff had a bad experience, they try to convert the same bad experience into the patient. Whereas when they change the behavior, otherwise, they themselves realized that I did wrong with the patient, but once I started correcting my behavior, the patient started appreciating. And the fourth one is the audio visuals we utilize to enable the rich discussions and active involvements. Especially that the basic life support trainings, they were very useful. We gave it to the home guards also. If you can see the different photographs of different training levels. Next. So these are the photographs of the training launched modules of the TOTs. We made 9 batches of 2 days each. Total almost 400 training of the trainers had been done, and it had been imparted to all the and then it has gone to all the districts out. Next, facility level trainings. These are the photographs of some modules trainings that have been done. Next. So this training, if you see, this is Kanpur one. This is a power walk kind of a thing, and the second one is a situational conditions we had given. Same based. You can see this. This is a hands-on training for the basic life-saving training on the mannequins. We gave it to the home guards as well as to the Sainik Kalyan Nigam guards outside the hospital. Next, please. So out of the 108 hospitals, 87 hospitals, district hospitals have already started the training, and 18 have been saturated. And we try to find out the results from those 18 based upon their experiences and the present feedback. You see the blue lines is the before the training feedback of the patients. After the behavioral training, there is a dip. The green one is, and after the training, the behavior has been mapped up. So this is, though there seems to be a very marginal low, this thing, but it is only an outcome of the 6 months training and the feedback and follow-ups. So hopefully the same thing goes on. If you see in this Unnao, so some data had shown 100%, but the fall is still 40%. So others are marginal, but the change is positive. And when there is a positive, trends are there, we would like to leverage it for the future years as well as. Next, please. So this is our tagline is satisfied client and a satisfied service provider. An example of a service provider, Tabassum Award Aya, she has appreciated the training outcomes and her change in her behavior, and a patient who has literally, he has told that it is better than Max Fortis, and I take it as an exaggerated one, but this is the way he would have expected a hospital should have been, but it's a good one if he compares with the private one. So the words could be something little exaggerated one, but it shows the emotions that he is happy with the result. Next, the way forward is that we want to reward and recognize and review this Mera Hospital portal and try to find out many more further improvements in the behavioral trainings in the coming years by supervision, hand holding at the different levels and going for third party evaluation. With the motto, the satisfied client and the satisfied service provider, we would like to convey to all through this that दूसरों से वैसा ही व्यवहार करें जैसा आप अपने से उम्मीद करते हैं. इसी के साथ में whatever schemes will be there, if our human HR is not trained to take up in the real humanistic angle, because health is something humanity based, then our schemes are not going to success. That too, if even if they'll be success, they will not be sustainable. Thank you all.
Thank you so much, madam. Well, that brings us to the end of the state presentations, and thank you to all the states for sharing your best practices, and congratulations for doing such commendable work. So I would request all of you to please applaud for yourself. Before we move to the last discussion for the day, which is on daycare cancer centers approach, and there are two states who would be sharing their experiences, Odisha and Tamil Nadu, exploring innovative approaches and strategies to enhance cancer care and treatment. So I'll first request for the presentation by Odisha.
क्या हो गया Okay. Respected ASMD ma'am and delegates, um, so I will be presenting on the daycare chemotherapy center, and you know it is important now because in the recent budget it has been announced to establish the daycare chemotherapy centers in all the districts across the country, and we are proud Odisha as is the pioneer in starting this daycare chemotherapy long back in 2017 itself. So the why this concept has come. Yeah. Okay. So the incidence of the cancer is increasing, and every year almost 60,000 cases are identified or find out, and then almost 60% they could not able to complete the full course of the treatment also. And then the limited tertiary facilities also, which is mostly located in the Bhubaneswar, Cuttack and all. And then a limited number of the specialists, oncologists available across the state, and overcrowding of the tertiary care facilities also, since only wahan pe our services are available, and a large number of patients, because of that they could not able to complete the treatment. One is because of this overcrowding and a limited number of facilities, and they have to travel for a long distance also for the continuity of the treatment and all, and by thereby it increases the out of pocket expenditure for the patients also. So in order to avoid all this, in order to improve the situations, so we previous slide. Okay. Next, next, next. Next. I think so. We have come across this concept, Odisha Comprehensive Cancer Care Plan, which has the different subcomponents like expansion of the State Cancer Institute, and then the strengthening of the tertiary cancer care facilities, and establishment of satellite cancer centers in across the 11 district facilities, and strengthening the daycare cancer chemotherapy centers, and then doing the cancer registry. And these are the components under the Odisha Cancer Care Plan. Just go back. Okay. So first inter. Okay. So in the cancer district cancer care center, the first intervention is identifying the daycare cancer centers in each district. So we have instructed the district health team to identify the space, existing space. It has not, it's been not, it's not the new building or anything. We have renovated the existing space. It is approximately only 1,500 square feet, and then whatever the civil infrastructures and everything, it's almost only for the 1.60 lakhs. It's not much expensive also. And we provided the provision of equipments and furnitures and all other equipments, furnitures, everything has been provided also, along with the biomedical waste management system in place and everything. Then next is, once the center is established, then how to run about it. So we have identified the doctors and nurses, and who are all interested also among the specialists also. So we have trained them. Almost 4 to 6 weeks has been trained. They have been tagged with this tertiary care facilities also. And even in Madhya Pradesh and everything, we tagged with other facilities, we have trained them. And after training the centers, and they have the continuous medical education also happening. The both mentoring is also happening physically and virtually also. They are mentored frequently. And then even during the treatment, they take the teleconsultations with the tertiary care facilities also. Then next. So after this, we ensure the provisions of the anti-cancer drugs and consumables. So we have the anti-cancer drugs in our EDL, and then medical corporations, Odisha Medical Corporation procures it, and based on the indent received from the district team, and then we supply it through the medical corporation itself. And other consumables they procure from the hospital itself. And then after training, everything is over, then they started providing the services, and further follow-up happens at the tertiary care centers. And then even the tertiary care centers, the doctors from tertiary care centers goes to the once in a month or once in 3 months, they plan their visit. They visit the daycare chemotherapy center. They do the consultation camps also. So for following up the old cases, and then to check the new cases also, screening of the new cases also they do. And then we have the format, which is of offline format we are getting. We are in the process of streamlining it by getting the online format and all. Next. So this is anti-cancer drugs, and as I mentioned before, we have the Niramaya under the corporation procures, and almost out of 121 drugs, we are able to procure 86 drugs, and we could be able to supply it. And each batches are tested before the supply to the districts and all. Next. Next. So the services offered in the daycare chemotherapy is mainly the follow-up treatment of the patients, and then the teleconsultations if needed, and then the screening for the new cases in the through camp based. And then we have the integrated palliative care also, and the doctors has been trained for the palliative care treatment also. Next. The flow of patients is mainly once the Ayushman Arogya Mandir, if they are screened. So they are referred to PHC and CSC for the medical doctors confirmation. Again, the medical doctors screen them, and further for biopsy or other early diagnostic, they send it to the district hospitals. And district hospitals may they do the medical test and other biopsy record or ultrasound, everything. And then they for confirmation of the diagnosis, or once they get the confirmation of the diagnosis, they send it to the tertiary care hospitals. Tertiary care hospitals may they do the treatment if it is required, the surgery or the radiotherapy or chemotherapy, whatever, whatever the more based on the stages of the cancer, they take up the treatment. And once the surgery or what chemotherapy over, the list from the tertiary care hospital comes to the district hospitals, and then the further follow-up of the chemotherapy or continuous cycle happens in the districts. And from the districts, the list goes to the PHC also, where the home-based palliative care. It is a team comprises of the physiotherapist and then CHOs and Ayush doctors goes to the community, and then the palliative care is also formed. So this is the entire flow of the district, how the district care chemotherapy centers function. Entirely the how the cancer patients are treated and then further follow up. Next. So we have we almost in all the districts, like 30 districts have the district daycare chemotherapy centers. And we have those state cancer institute apart from that. And then in tertiary care facilities, in medical colleges, we have the radiotherapy and again chemotherapy in both Bimsar Bulla and then MKCG Berhampur. Next. So the resource mobilization is almost since it was done in 2017, all the resource mobilized are entirely from the state budget. So we have for the establishing the chemotherapy centers, and then the provision for the drugs, we are keeping it now in the NHM PIP and all. And the training of medical officers through the state budget has happened. And the mobility and arrangements for the cancer screening. When the tertiary care, when the oncologists visit the districts, they do the screening for the community for the screen for the patients who are screened or for the cancer at the field level. So for that we have kept the fund under the state budget. So on an average, the each district's the expenditure was around 41 lakhs that time to establish this. Next. So the outcome is till 2018, only 3,000 odd the patients were getting the chemotherapy, but it has increased to 9,000 patients getting the 20,000 cycles. So it's increasing. So this many patients no need to go for the tertiary care facilities just for the continuation of the chemotherapy cycles. So we hope we are saving them their expenditure also, and they could be able to complete the treatment also. That's the positive outcome of it. Next. So apart from this, we have the free diagnostic services. We have provided colposcope and thermal ablator, everything. We have at the DHH, we have trained the doctors, the specialists also on this. And then apart high-end investigations also we have provided pap smear and this they are the doctors and the specialists are trained for this again. And we have the radio diagnosis, USD and CT scan, MRI and all in the DHH facilities and in the PET CT scan in the tertiary care facilities. And then we have the molecular diagnosis also 10 in number established. So the districts are tagged to the 10, and to identify the particular which tissues or where the cancer arises, they send the district team send the samples to this tagged molecular diagnostic centers also. Next. So the way forward is under Odisha Comprehensive Cancer Program, we are planning to strengthen this 11 regional centers, so that we are hoping like we could able to address the needs of the many people that as we pointed out, 60,000 new cancer cases patients are identified every year. So most of the patients go out of the states, most of the patient goes for the TMC for the care, and also with this establishment of the regional center in the 11 districts, we hope we could able to cater the needs, and most of the DD patients will be able to get the benefit, and then even the nearby states can also, their patients also can get treatment here. So that's we are planning, we are in the process of establishing it. And apart from that, creating more awareness on the habits, on this lifestyles and everything, and then strengthening the screening in the Ayushman Arogya Mandir. That's the basic. Once the strengthening is increased and we could able to screen more cases, and then further we can do follow up for the further treatment, and then we could save the lives of the patients. Next. So thank you.
Thank you so much, ma'am. Now we'll request for the same presentation from Tamil Nadu on their experience sharing.
A very good evening to all of you. Next slide. So I'm just going to, I should say that already ma'am has given most of the presentation which I was supposed to do because it's going to be the same across. But I'll just run through the progress made in the at the district level oncology care in Tamil Nadu. Next. So this is basically about the population of 7.73 crores. These are the major cancers which are in Tamil Nadu: oral cavity, stomach, lung, and here breast, cervix, and ovary in the case of women. Next. So as of now, we have around 14 districts which have oncology departments in the tertiary care facilities. The 24 districts which we say lack government care facilities in the sense they do have oncology, but not all the three. The medical, surgical, radiation, all the three oncologies are not available. But 24 districts do have facilities for the cancer treatment, which is the daycare centers. Next. This is the existing infrastructure in Tamil Nadu. From the government side, the public sector, we have around 11 Linacs, 15 Cobalt, Blackie 9 and 10 PET. And empaneled institutions have 45 Linac and 14 PET. Next. So the onco care, the daycare chemotherapy actually started in Tamil Nadu in the year 2018. So since 2018, we have been doing this. Post COVID, there was a lull because most of the activities were diverted towards that. But later on, now we have started picking up this activity again in Tamil Nadu. If you look at the data, in 2018, 28 government hospitals and 4 government medical colleges had it. In 2021, we upgraded 11 district headquarters hospital into medical colleges. So they all got the 17 government hospitals and 15 of them had it. And right presently, 38 of them, 18 in government medical college and 20 in government hospitals have daycare chemotherapy. Next. This was actually the process of implementation, the initial stages. Basically, we did not go for much. 2 beds in the medical ward of both male and female. And there was supposed to be 1 physician per institution who was supposed to do that. And these were some of the equipments which are very, very basic, which are supposed to be there in the wards where we administer chemotherapy. Basically, the multi-para monitor. Main important thing is the crash cart with defibrillator, which was supposed to be there in all the wards where we administer chemo. Next. This was the process of implementation. Initially, what we did was we had a meeting. Basically, there are 3 wings in Tamil Nadu: the primary, secondary, and tertiary. Each of them headed by a director. So, basically, the Directorate of Medical Education is the tertiary sector, and the Director of Medical Services is the secondary. So, involving both the officers from the departments of both the directorates of both medical services and medical education is very important. So, we had the coordination meeting with them. What are the cancers that can be treated at the tertiary level, and what are the chemo which without any issues which can be given at the secondary level? That was first done. What are the type of chemotherapy to be provided? So some drugs were shortlisted which can be given at the secondary level. The referral process from the secondary to the tertiary and tertiary to secondary for the purpose. So they used to maintain registers and ensure that they are followed up, and the telemedicine as well. The most important thing before starting this process was the training, which was told also by ma'am. So basically RGGH, we have the Apex institution, state Apex institution for basically the Rajiv Gandhi Government Medical College, Government Hospital, where we gave them training on the necessary pre-chemo investigations. So either in the morning or a day before, we have to do the pre-chemo investigations. Based on the results, we'll suggest the procedure of chemotherapy and follow them up for the management of possible side effects. The SOPs were evolved and they were distributed. The case sheet format was standardized, and also the chemo reagents were made available at the secondary and tertiary levels. We have the Tamil Nadu Medical Services Corporation, which is very robust and helps in seamless supply of drugs to the field. Next. So these are the treatment guidelines which were evolved on the pre-chemo day, on the previous day to the treatment, or on the same day in the morning. So this was the strategy which was followed. And on the day of treatment, what is supposed to be done? So the training usually focuses on the pre-chemo or administering chemo, and also the post-chemo complications, how they have to attend. So these are the 3 major things which were given during the process of training. Next. And also the assessment of general condition as well as the pre-chemo investigations, which I already said, the BC, RFT, LFT, capillary blood glucose, and also what are the conditions, the values for which you can go for routine chemotherapy. Next. So these are some of the chemo regimens, say for 9 of them, which are just showing indicative. So how this regimen has to, what are the pre-medications which have to be given? So like this, for every regimen, there was a modus operandi, I would say, how it should be given. So basically the pre-medications, at the time, how you're calculating the dose, post-chemotherapy advice which has to be given, was given for every mode of treatment which was given. Next. So if you look at the numbers, most of us, this is, I'm very candid. I want to just tell about the challenges which you will face when you're going to open the daycare centers. So basically what is required, if you just look at it, it may seem to be very less, but all of them are going now to the tertiary because of no follow-up, because most of them are also, I'll come to the reasons in the next slide. So if you look at the insurance, next slide. So around 53 crores from the government side is being spent for chemotherapy, out of which we look at the tertiary, around 27 crores in the government sector itself goes. But look at the secondary, only 50 lakhs goes to the secondary, because most of our, every district has one medical college in Tamil Nadu. It's not like there are no medical colleges. So when they go to the medical colleges, usually in the district headquarters. So we have now redesignated another hospital to the district headquarters hospital, which we are now equipping with our secondary care the secondary daycare centers. So every district has one medical college. So naturally, there is no need for them to approach a secondary institution for chemo. But because you have now redesignated one of the sub-district hospitals as a district headquarters hospital, now we are going to bring in this aspect also into the new district headquarters hospital. Next. So these are the challenges. Some of them which are very, very trivial. Initially, the resistance from the oncologist to refer them for the chemo based because of the insurance benefits, concerns on inappropriate management of side effects, the income loss due to CMCHS, limited chemotherapy regimens identified by the expert committee, attrition of the trained manpower, and patients' preference to the tertiary care centers because they're available within the same district. And post-COVID, this had the functioning of the system at the secondary care centers was not properly followed up, so we had a lull. But now we are picking up again. Basically, what we do is once a case is diagnosed or referred from a secondary or a primary center with symptoms of cancer, they are referred to the tertiary center for confirmation. Based on the need, the tumor board sits and decides the course of management, whether it is radiotherapy, chemo, or surgical, or concurrent of all the three, what has to be done, that is decided by the tumor board. Once the tumor board decides the course of management, if it has to be medical, then the first dose of chemo is given at the institution, the tertiary institution. After giving the first dose, we are looking forward to have whether they have any allergic incidents, following which the second and third dose will be given in the secondary institution, the daycare center. The fourth dose is again asked to come to the tertiary care center for a follow-up. And based on that, the next two doses, usually 5 or 6 cycles of chemo is what usually is given in every case. So we ensure that at least couple of times, the first dose is usually given at the medical college or tertiary center. The fourth dose is given at the tertiary center, and the remaining 4 doses will be given at the secondary centers. Next. Now, this is the plan which is we are coming forward with to strengthen our secondary centers. The expansion of daycare chemotherapy, district level enhancement, workforce training, and continuous skill development, which I was talking about. Next. So I'll go to the next slide. You can go to the next slide. So this is the efforts to establish Onco Care. We are going to establish this cancer care centers in those 24 institutions which I spoke about. We already have one physician who has already been given under the palliative care. We have one a doctor who is also there under the daycare, which is already sanctioned at NHM. We have 4 staff nurses and 2 multi-purpose health workers. This is already sanctioned strength given by NHM, which is available in the state. So what we thought is now they are not located at one point. So we plan to establish a cancer care center in every institution where all the 2 physicians with 4 staff nurse and 2 multi-purpose health workers will be there. It will not be just giving chemo, but also these aspects which will be linked to it at the cancer care center. So if anybody is going to approach, it will be a one-stop contact at the secondary institution where they can be referred there. And these are the investigations which will be available in that cancer care center. Basically, the screening with confirmation using these methodologies, and then referring them to the tumor board if you have to go for surgical or radiation, or get the advice through telemedicine from a medical oncologist and start the chemo. at the tertiary level and then refer to the secondary level. This particular modality with the already existing strength, just bringing them under one umbrella without any new force, new manpower, the existing manpower with adequate training is what we look forward to. Next. So this is the model which with the waiting area, the nurses station, the consultation by the medical officer, the sample collection, procedure room for palliative, beds earmarked for both palliative and daycare. So this will be a combined approach which is going to be taken forward. Next. So for this, basically because Tamil Nadu has enough number of tertiary centers, around 38 in number. So we are planning to map those institutions. Right now, 14 have all the three radiation, surgical and medical oncology who are available. So we also have called them as the regional cancer care centers, 5 in number, with the Apex Cancer Care Center situated at Karapet in Kanjipuram. They will be act as hubs and we'll be designating the spokes, the secondary hospitals which they should do. And then the team will be giving them a dedicated team will give them training on chemotherapy. The sensitization will be done and the regular supply of chemo drugs will also be done and digitally captured using our HMIS portal. So this will be the plan for the new cancer care centers. Now it is already existing as chemo. Two beds are already there in all the institutions in the tertiary as well as 18 secondary institutions. But we will ensure that they are also designated as cancer care center where it's a one-stop contact for a person coming with any cancer signs and symptoms to be done diagnostics, referred for the modality of treatment at the tertiary, then given treatment at the secondary level. Thank you.
Thank you. Well, that brings us to the end of all presentations and the end of the first day of the summit. But we, of course, have a cultural evening planned later. But for now, we would like to take this opportunity to felicitate all our presenters. And I'll request Additional Secretary and Mission Director, NHM Government of India, Srimati Aradhana Patnaik, to please come on stage and do the honors and felicitate all our presenters from different states. Can we welcome her with a round of applause, ladies and gentlemen? So for the first presenter, I would like to welcome on stage MD NHM Odisha, Dr. Brinda D. For all your information, we are handing over a traditional Pattachitra painting. This is a traditional painting of Odisha, made on cloth and based on Hindu mythology. Very, very unique to Odisha. Please, let's welcome on stage MD NHM Chhattisgarh, Mr. Bijay Dayaram. So we are sure this Pattachitra will remind you of Odisha every time. MD NHM Andhra Pradesh, Shri G. Veera Pandian. Please welcome on stage MD NHM Manipur, Dr. M. Dinesh Singh. Let's welcome MD NHM Telangana, Shri R. V. Karnan. Let's welcome MD NHM Meghalaya, Shri Ram Kumar. Let's welcome MD NHM Madhya Pradesh, Srimati Saloni Sidana. Let's welcome ACS Health Kerala, Shri Rajan Khobragade. Let's welcome Secretary Health Himachal Pradesh, Srimati M. Sudha Devi. Let's welcome MD NHM West Bengal, Mr. Subhanjan Datta. Let's welcome MD NHM Uttar Pradesh, Dr. Pinky Joel. Let's welcome once again MD NHM Odisha, Dr. Vrinda D. And last but not the least, please put your hands together for MD NHM Tamil Nadu, Shri Arun Thamburaj. So thank you to all our presenters and thank you, madam, for doing the honors. Ladies and gentlemen, we will now have a break till we meet again at 7 p.m. for the cultural evening, which will be followed by a gala dinner, which has been arranged at Mahari Courtyard, third floor. Yes, they were not there. I was informed they have left. Acha. All right. All right. So we have MD NHM Karnataka, Sri Naveen Bhatt. Someone is all right. So somebody is collecting on their behalf. And I think for MD NHM Jharkhand, we had Sri Abu Imran. If someone can collect on their behalf. Representatives. All right. So, ladies and gentlemen, like we were saying, we now meet for the cultural evening, followed by the gala dinner at 7 p.m., which has been arranged at Mahari Courtyard, third floor. For now, it's a wonderful opportunity for all of you to relax, socialize, have some interesting cuisine, experience that you won't miss. Also, if you want to explore the town, engage in some shopping, or simply take a stroll on the beach, please coordinate with your LOs. And we would also like to invite you all now to join us for high tea. Do join us for high tea. And as far as anything that you want to coordinate with your LO, any information or assistance, you can contact the help desk at your respective hotels. So thank you for your active participation. Enjoy the evening and see you all at 7 p.m. at third floor Mahari Courtyard. For now, do enjoy your tea break. Thank you, everyone.